Some of you know that, and those listening know that the directive for Bob Bethell, which we're going to take a hard look at, by the way, is that we meet once a quarter, but during session, they ask that we meet in January. This is obviously February. One of the changes that were made this year was having the budget hearings on Fridays, and that's when we were trying to meet. So I realize we've changed this now. I don't know, I lost track, I think 3 or 4 times. We finally just had to pick a day and stick with it. No, the House went very long yesterday, so we have several of our members that will be virtual. So don't be alarmed if you don't see them in their chairs. They will be listening. And again, appreciate you all coming out today. Do we have any announcements? All right, seeing none, we're going to go directly into our sorry, I'm used to normal committee. Responses from Q4 2024 meeting, and we'll begin with Evan Dean, Associate Director of KU Center on Disabilities. So they're on the website. Oh, I'm so sorry. It doesn't say on the agenda that they're written only. Okay. Thank you so much, Elizabeth. We also have lots of written-only testimony on KanCare from individuals, providers, and organizations that you see below. Committee, I would really urge you to read through these. Very important. We ask them to give us reports, and then we need to be sure that we read them. So now we will see written-only testimony from Suzanne Luker, who's the KanCare Ombudsman, and we will start with the presentation of annual report from Haley Ordorn, which is our long-term care ombudsman, and she's in the committee room. Thank you so much.
Try that again. There we go. Good morning. Good morning, Madam Chair and members of the committee. It's nice to see familiar faces so often again, and for those of you virtually, nice to meet you all. I am Haley Ordorn, your long-term care ombudsman, and though I'm not new to long-term care, as many of you know, I've been in front of you for many years. I am, however, new to this role as the long-term care ombudsman. So I wanted to kind of give a little bit of a refresher. Our annual report, we do a lot in a year, but to condense that down, I'm going to try and be pretty precise with you. But I wanted to focus on, and I do have presentation. I don't know if that's pulled up. Okay. But I'm going to, okay, we're ready to go. I'm going to go ahead and start in. So I first wanted to focus on really what is the long-term care ombudsman? What is our role? What do we do? What is our function? Because a lot of what we still remain to do is education to the public, to everyone in general. But what we do is we are resident-directed advocates. So our primary focus is solely on the residents that live in adult care home settings, nursing homes, assisted livings, home pluses, those sorts of settings. We're there to advocate to make sure that their resident rights, civil rights, human rights are always upheld. And we give a voice to them because oftentimes if you're in a situation where you're dependent upon someone else to provide your cares, sometimes you feel like your voice isn't always heard. So that's why we bring an extra element to that. And how do we do that? What do we do? Sorry, page 2, please. We investigate and resolve those complaints. We educate the residents on their rights, the facility staff on how to bring those, make sure those rights are being followed. And we also educate the community at whole on what rights are, what resources are available. We obviously come here and we advocate for policy changes that impact anyone residing in an adult care home. And we do a lot of regular routine visits to these settings just to make sure that we are accessible to those individuals and also to check on the quality of care and report accordingly if anything needs to be referred out. We're trained to resolve conflicts and situations and work to ensure that the resident wishes are the center of any sort of circumstance. One thing I did want to touch on is that we are not mandated reporters. I know that seems to kind of surprise people at times, but we have a level of confidentiality with the residents that we discuss, and since it's by their discretion and direction what course we take to resolve a complaint or take action on, we are not mandated reporters. Page 3, please. So here's just a few of the ways that we educate. A lot of what we do also is building connections and relationships. So it's very important for us to educate the residents on what their rights are and what regulations there are to back that up. We also attend resident councils and family councils to provide ourselves, again, resources and education. We offer to provide staff in service and education to the individuals that work in the adult care home settings. We also educate through provider associations such as Leading Age, Kansas Healthcare Association, and Kansas Adult Care Executives. So it's important for us to network and have that relationship. We participate in multidisciplinary teams, and what that is we work with law enforcement, KHP, Attorney General's Office, Medicaid Inspector Generals, KDHE, KDADS. Lots of networking to know that if we don't have the answer, we know who does. We also network with many other community groups and providers. I know Minds Matters is here, brain injury. We network with everybody who can bring something to the table to help ultimately support residents and their rights. And in 2025 and going into 2026, our big goal is really to bring a lot of community education to people across the state and social media platforms to those that aren't always easily accessible. Next page, please. Who can contact us for help? These are where we primarily find ourselves being contacted, but honestly, anyone and anyone can contact us about resident rights or if they feel that those are being violated. So you all can contact us. Everyone in this room can contact us for any concern related to that. But that's where we normally find ourselves being contacted by residents, concerned family, friends, staff, and then outside referring agencies, Adult Protective Services, DCF, KDADS, things like that. Next page, please. This is a quick summary, and I will tell you, I probably can't go into too many details because my term started in July, and so I had 3 months of this one-year report that I'm giving you. So I will do my best to answer any questions at the appropriate time for you. But this is a quick summary of really what we have done. You can see down to the bottom right who we all serve and the number of beds, licensed beds that we are there for. So those are all the facility numbers, residential care communities also. And 7 minutes goes by really quick, and that's okay. Continuing on, you can see more of the additional testimony of our top complaints and what we focus on and what we're here to really, provide for. So I'm happy to answer any questions for you at the appropriate time.
This is the appropriate time, Haley. So I'm going to open it up for questions, and maybe some that you weren't able to address will be brought up in the questions committee. Okay. Are there questions from our members that are on WebEx or members here in the committee room? Representative Bryce.
Thank you, Madam Chair. Hi, thank you for presenting. I'm new, so I have a couple quick questions. One is you said anyone can contact you. I was wondering, is that through a particular? Oh, this is the phone number. Okay. What kind of staff do you have to investigate all of these complaints? I was just wondering about numbers and staffing and so forth. Thank you.
Yeah, absolutely. Thank you for asking, and welcome being new too. We have a team that we have a lot of regional staff that go out, and we're divided. That's available on our website information also. But there's a total of 12 of us right now. We are all licensed. All of our we are all certified ombudsman. All of our volunteers are too. Our volunteer numbers did take a hit during the pandemic, so we have lower there. We're working to build that up, but we have a team of about 12 that divides and conquers throughout the state, and we go in and receive complaints. Sometimes it's referring to an outside agency, but other times we go in, we investigate, and work towards a resolution through that process.
Additional questions, committee? Senator Petty.
Thank you, Madam Chair, and thank you, Suzanne, for being here. I know that on the Senate side, we just passed out some legislation concerning training that when it comes to Alzheimer's. I'm having Alzheimer's right here. And It won't be the first or the last time. And so, I mean, it's a bill that's moving along, but in that role, will you be doing the training and then with staff at locations, or will you be providing that information so they can be doing the training in their own facilities?
So with the bill language, the way that I understand it, we support the fact that everybody needs dementia training. Prior to this, I was a dementia consultant. So side note, I feel very knowledgeable and supported about that topic. The bill, the way that I understand it, is for our office, our 12 ombudsmen, to do that training. It is not intended for us to then go out to providers and do that sort of training. But that is, and I see head shaking for language interpretation. But my understanding is that we within our office, i.e. me, resources that we have would be the ones doing the training. I know that the Alzheimer's Association has resources available if we need to seek that outside, but that is our understanding of how that would be done. And it is a requirement through the ACL that oversees our initial certification and our ongoing annual certification to have Alzheimer's and related dementia training already. So that is a requirement for us because there are parts in there that go into, communication and understanding the disease and understanding how that can impact their journey in an adult care home setting. But where we stand is that we also receive that training in general, because a disease that someone has shouldn't be a label that makes a change of their care needs. Everyone, we focus on individualized, person-centered care. So a care plan for every single one of you up there is going to look completely different, as it should, regardless of the diagnosis that an individual has.
Just as a follow-up, so are you already receiving this training, and so this really doesn't change that much as far as your specific training that you already have?
Yeah. Yes, thank you for the question. So we do already do the training, and in fact, our team all meets quarterly in person for in-person training. And this last, I believe it was July when we met last, we went through and provided training on the stages of dementia and how the disease progresses and what needs look like differently. So that was just one of our most recent ones. So it would not change the fact that we're doing that. The part of the bill when we had the hearing that we proposed be amended was all the line item language, because there's very specific line items within that we don't feel, and our governing authorities on the federal level also did not feel were beneficial to us, because we don't provide direct care. It seemed to be more provider written language for, the staff, for EMS, for those, whereas with us advocating for, resident rights, that there's certain things within that doesn't change.
Thank you.
Additional questions, committee? Seeing none, Haley, thank you so much for being here.
Thanks for the opportunity.
Madam
Committee
Chair, I
next.
have my hand raised. This is
Oh,
Representative
I'm sorry.
Susan Ruiz.
Was there a hand raised? And I don't know who's speaking.
This is Representative Susan Ruiz.
Representative Ruiz, please go ahead.
Yes, thank you, and good morning, committee. I was wondering about a question for the ombudsman. It is can families call and have when they have concerns about possible overuse of antipsychotics in nursing homes?
Yes. Do we receive those calls? Absolutely. Can we intervene for those and advocate? Yes, we can. So in a circumstance where a family would contact us like that, we always take direction from the resident. So we would ask the family, this is our process where we would refer to the resident. We would go to the resident and say, we've received this concern complaint from your family member, how do you feel about this? What is your wishes? Do you want to be on this medication? Are you aware of the side effects? Do you not? And then from there, we take the direction of, okay, yes, I want to remain on this. I feel that it improves me. Okay, great. Then we go back and, tell the family their wish is to stay on this, and that's what we're going to advocate for them. And if they say, no, I don't want to be on this, I really would like to try alternative measures, then we say, okay, great. Do we have your permission to collaborate and network with your care team at the adult care home and look at alternative uses for whatever diagnosis that they have that they're using that medication for? So yes, we absolutely do.
Madam Chair, I have a follow-up. Is it, in future meetings, you will be giving us a report on everything, on, like numbers of calls and things like that?
Yes, in my written testimony here, there is some of that information, but yes, I do present a more expanded annual report to some of the other Senate Public Health, Health and Human Services committees that go a little bit more into depth. And also, I'm happy to have any more in-depth conversation with any of you at any given time.
And I have not looked at the report yet. So I don't know if there's a section there just devoted to, concerns regarding the possible overuse of antipsychotics.
I can be sure to forward you that precise information.
If you could forward that to committee, that would be great. Representative
Thank you.
Ruiz, if on your S drive, if you took your Senate or your
Yes, I know where it is. It was just a late night.
Oh, I know
Thank
it
you.
was. I'm sorry. I'm just going
I have to set up, I'm going to have to set up two laptops here so I can keep it all together.
I understand that, and I typically
thank you
don't
so
take mine
much.
home. That's why I ask if you took it home. And committee, it's on page 5 of her testimony, of her PowerPoint, the number of cases and complaints. This brings up a question for me, Haley, and that is, you're not a mandatory reporter, as you stated. However, do you report if you see signs of abuse or something of that nature?
If we have the residents' permission, we do. Yep, we take our direction from the residents. So oftentimes there can be cases where we believe abuse has occurred or the resident does feel that abuse has occurred, and if they do not want it reported, that is where we take the direction of the resident and it stops.
I guess I could see that if they were in independent living, even assisted living. But in some situations, they have a power of attorney for a reason. They're not capable of.
Yes, in the cases where they do have a substitute decision maker, then we would go to them on that, yes.
Okay, thank you so much. Committee, additional questions? Thank you, Representative Ruiz. Anyone else on WebEx that we're aware of that has a hand up? If you could let me know. No one? Okay, thank you so much.
Thank you.
Committee, we will now move on to Steve Anderson, the Medicaid Inspector General. Welcome.
Chair Gossage, members of the committee. My name is Steve Anderson, Medicaid Inspector General. Thank you for the opportunity to appear today and discuss the Office of Medicaid Inspector General with you. Our 2024 annual report had been finalized and filed in accordance with our statute. I also provided a copy of that report to each of you. I'm sure everybody's read it with all the other things you have in front of you. In cooperation with KDHE, our office has developed a fraud, waste, and abuse awareness training that provided to KDHE as well as contract employees and public citizens. In the past year, we conducted 14 virtual and in-person training sessions to 339 people. We also had an online session that was provided to a lot of the Healthy Blue people that they could use anytime they wanted to, so we don't track those numbers. Obviously, the purpose of the training is just to provide information so that people are better prepared to identify fraud, waste, and abuse and how to report it. I also want to point out the number of complaints of fraud, waste, and abuse and legal acts concerning Kansas Medicaid programs, which also includes Medicaid, Medicare, and CHIP, have increased each year. In 2024 calendar year, we processed 1,454 complaints, with 1,318 of those complaints involving allegations of eligibility fraud. We break it down further. Of the ones who were not eligibility fraud, there were 36 complaints that did not involve Medicaid and referred to the correct agency. Had a complaint that involved a state agency, another one involved a state employee. We also had 22 complaints of beneficiaries committing non-eligibility fraud, something like identity theft. We had 76 complaints that also involved providers and contractors. And there's a chart on the handout that kind of shows you the year-over-year progression of the number of complaints. It's kind of leveled off, but each year it incrementally goes up. There's also a breakdown below of how we handled the complaints for calendar years 22, 23, and 24. And one of the ones I want to point out is the determination of no fraud, no jurisdiction. It's based upon our preliminary review of the complaint. We look at it and we find that there's nothing there. Oftentimes we get allegations that are made that involve somebody say, well, this person's on Medicaid and we don't think they should be. We take a quick look at the systems and we're able to determine that their Medicaid had actually been cut off 6 months before or a year before, and the person just didn't understand what they were saying, so we're able to easily close those complaints out with that information. Also want to point out our investigative staff came on in July of 2023. We're addressing the backlog of open cases and processing new allegations as they're received. The state of Kansas program, as everybody I think probably is aware, is about a $5.5 billion expenditure, and it seems like every year the costs are going up. Last year, the Medicaid program served an average of 467,440 beneficiaries. And it's a big program, a lot going on. We have 10 people trying to hold back the entire thing, but we're doing the best we can. We have 2 performance audits that are going on I want to tell you about. Both of the active stages of those audits have been completed and draft reports are being prepared and finalized for comment. The first one involves the prior authorization process in Kansas for Medicaid recipients as compared with the MCOs and how they're doing that. That audit period covers January 2021 through December the 31st, 2022. The second one involves Medicaid reimbursements for schools. I'm actually pretty excited about that one. I think we're going to find that there's some real opportunity for savings for the state of Kansas and the Medicaid program with that. The scope of the audit includes all Medicaid enrolled students who had services billed on their behalf with local education agencies. And that again runs from January 1st, 2021 through January 31st, 2023. It was one of those things I didn't know until we started looking at this, that the state of Kansas pays about $25 million a year in fee-for-service claims for students who are receiving Medicaid-related benefits while they're at school, speech therapies, those sort of things. And I was surprised it was paid fee-for-service versus being paid by the MCOs. So that report will be out shortly, and I think it'll be interesting for everybody. I also want to talk about an example of an investigation that we have involving Medicaid providers billing for what we call impossible hours. And what that means is they're billing for hours totaling more than 168 hours per week. You would have to work 24/7, 7 days a week to get 168 hours in. And we also have numerous other claims where they averaged 8 to 24 hours per day. That's their billings. We looked at that. They billed for over $7 million. Do I get to go on or do you want me to stop?
We are giving everybody 5 minutes, but again, you will probably see that in the questions, you might be able to continue with your presentation. Committee questions. Senator Erickson.
Thank you, Madam Chair. Thank you so much for your presentation, Mr. Anderson. Just a quick question. I see that your audit work has identified $300 million in wasteful spending, $6.3 million in overpayments, $25 million in potential savings. And I see the word, you've identified it in their potential. How much has actually been saved?
This year alone, we're saving $12 million. That's a hard savings, and that's because of a change that was made with continuing care retirement centers. We had that, we suggested a change be made for the legislature to move that responsibility there from the Department of Insurance to KDADS, and because of that, facilities that were no longer billing at the wrong bed tax amount, they went from being able to pay $818 per bed per year, and then they were assessed the correct rate, which is $4,908 per bed per year. So because they're actually being assessed at the correct rate, it's going to save the state of Kansas approximately $12 million a year in state general funds. That's not FMAP, that's not federal matching, that's 100% state general funds.
Thank you so much for that. But I see that there's $330 million that you've identified. And I understand you make recommendations to agencies.
That's
What
correct.
happens after that? Do they
That's up
have
to
to abide by your recommendations?
They do not. That's merely, we can point it out, but we can't make them do it.
Thank you, Madam Chair.
Representative Sutton.
Thank you, Madam Chair. You mentioned a broad host of agencies that benefit from your services, Medicare being one of them. Yesterday was it yesterday, the $1 billion guilty verdict or guilty plea? Did your office have anything to do with the investigation of that crime?
I guess not, because I don't know what you're referring to.
There was a, I'm not going to say names, I think, in a committee. I think that would be probably wrong, even though it's pretty public. But yeah, it was a $1 billion deal of defrauding Medicare, and it was a Kansas City guy, right here in Overland Park. So I was wondering if there might have been some overlap here.
Well, Medicare, Medicaid is the difference. We don't deal with Medicare at this point, so it was probably Medicare is what you're seeing.
It was Medicare only then?
As far as we know, sometimes we see those news stories and we'll actually look to see if there's any Medicaid exposure.
Might be cool. Might be
Yes.
cool to look at.
You bet.
Thank you, Madam Chair.
Additional questions, committee? Senator Petty. Me. I walked right over Representative Ballard. Representative Ballard, I had your name down here.
Thank you. I have two quick ones. Overpayments. I see you have $24,921, and you said potential savings.
Right.
How are you able to get that money back, or do you ultimately have to write it off?
Well, on any that we have no ability in my office to force it. All we can do is make recommendations to this body or to the legislature. We make recommendations to the agency for like KDHE or KDADS, for example, of here's an area where you could potentially save this money. The $12 million I was talking about earlier, that is, we know that's happening because we've been in contact with KDADS and those facilities are being properly assessed. So we know that savings is happening. There's been other examples where we said, hey, these people are no longer eligible. There's on the Transmed, for example. They were able to stop the bleeding right then. That's savings. Whenever you can just stop, the hemorrhage. If you have a significant water leak at your home, you shut the water off, you're saving money because you're not losing that water. So that's a savings. We also are involved in a situation several years ago now, it seems like, where we had people who were deceased that were continuing to draw, being contained on Medicaid, right? And they hadn't been removed. We identified those people. They stopped the capitation payments, which is those monthly fees that we pay to the MCOs, and that money was recouped. That's the good news about that. If it's somebody who's deceased, they will actually recoup that money in those situations. Other times we've identified money, the KDHE opted not to recoup the money. That was their choice. We can't demand that they do that.
Okay. The other one you indicated for reimbursements in schools, and I think you said $25 million.
Right now, we understand that $25 million is being paid via fee-for-service to schools for providing services for Medicaid beneficiaries.
So how are you figuring you can have 25? Who's going to be billed then if you're going to get it from schools?
Well, the MCOs are already being paid capitation for those same students. And our recommendation is going to be that these people, the schools should be billing the MCOs and not fee-for-service, because we're already paying the MCOs capitation for the same services.
I understand that. I figured you were going to go for them, but then why should they be then doing it in schools? Because it's on school district time. I understand how you're going to do it, but I don't understand why they have, I guess MCOs would be responsible for it when it could be very much related to schools.
Well, it's the services if the person needs like speech therapies or counseling, behavioral counseling. It's being provided in a school setting while the child's at school, but during the summer months, then in some cases the MCOs are actually taking care of it. But during the school, that cost gets transferred to having the school still doing the services, but instead the state of Kansas is paying for it directly, and the MCOs are being relieved of the responsibility of paying for those services when they're still receiving the same capitation
Okay.
that they're receiving. It's one of those things that seems sensible that why is the state of Kansas paying for basically twice?
Yeah. All right. Thank you very much.
You're welcome.
Senator Petty.
Thank you, Madam Chair. So, Steve, you mentioned on the chart that's on page 2 about the complaints that were brought forward, and as you have listed there, no fraud, no jurisdiction. I'm looking at 24, and there were 219 that were thrown out the door. And that if I look at investigation open, that of the number, and then you have listed the average number of beneficiary are over 467,000 Kansans that are beneficiaries. So this number is out of that. So we're talking about less than 4%. Would that be correct?
I haven't done the math on that, but, and again, all this is just based on the complaints that we receive. It doesn't mean this is, and I've had other people work those kind of numbers on me. It doesn't mean that's the totality of the fraud. It's just that the complaints that have been received. A lot of people don't know to report fraud.
Right. And we also know that sometimes people, just as you said earlier, will say that there's fraud going on. That person no longer is a client. They don't know what the beneficiaries are. They just see someone do something and they think that they are committing fraud. So you made that statement earlier too,
Yes,
that
I
some
agree.
of them are frivolous reports as well. And I guess that would fall under the no fraud jurisdiction that you've thrown out.
Yep.
So when it says sent for review, what does that exactly mean under the complaint research?
Sure. What that means is that we looked at it, gave it a preliminary review. If it wasn't something that was very, very clear cut where we could open an investigation on it, we would send it on to the clearinghouse through KDHE for them to conduct their own review. And in situations where it may be something minor or something that the eligibility staff can review and make a determination on, we're allowed to do that. Part of what drives that is I have to tell you, there's cases every day that come past my desk because I review every single complaint that comes through our office. I simply don't open cases on them even though I could because we just don't have the staff. That's one of the things, the reason I'm asking for more people, is if I had the additional staff, we would open more cases. But because we don't have the resources and I can't kill my investigators and my special agents, we move it on to the clearinghouse and let them take whatever administrative actions available to them.
Because we do have staff within, just as you said, within the clearinghouse, we do have that staff there. So often, it seems to me, what you're talking about is a duplication of services. And this legislature, and we hear this at the national level as well, are talking about efficiency. And so I'm not sure I understand efficiency when we talk about we have to have duplication of services. You just said you send these to the clearinghouse, you have investigations open on 4% that you are following through on. I mean, I can understand that, but I don't really see the need of having another layer that has to go. That, to me, that's assuming, and I'm not going to assume this, that we have that our MCOs are fraudulent, that our Medicaid program is fraudulent, and or that our departments are not doing their job, and that's what they spend their time doing all the time. So I guess I know that you've been before committees to justify this and talked about why you want these more state positions, but this shows that we have in place ways to look at that. And the recovery of funds, so if I go down here, you've been using your 10 staff members right now to conduct these investigations, which is an added layer as it is. Would that be correct?
Nope. I disagree with you respectfully. Our focus, again, some of that staff is doing audit work, not investigations, to be clear. Also, we look at that from a standpoint of criminal stuff. Anything we send on to the clearinghouse, they're merely looking at it from an administrative standpoint, and it may be something where the person hasn't reported a change, and it's something that can be easily resolved. Those are the ones that get sent to the clearinghouse. We also get ones that go through the clearinghouse. Their people look at it, and they say, oh, there looks like there's something here that's fairly serious, and they will occasionally make referrals to us because it demands further investigation. Our investigations do not look for administrative work. We're looking for individuals who are committing outright significant levels of fraud that's criminal and for prosecution. Clearinghouse is looking for people they're able to administratively fix it. But like I said, I see some that go by my desk every day that is, if I had the resources, we would be able to pursue more criminal cases for people committing outright fraud. This is people that are making significant income and they choose not to tell Medicaid, and they enjoy the benefits of having their entire families on Medicaid benefits and getting free health care while they would no way qualify for Medicaid financially. People that moved out of the state of Kansas and sometimes they're getting benefits in another state, but yet they continue to hang on to Kansas benefits even though they're no longer a resident of Kansas. And this goes on for years. Those are the people we're looking for. So it's not duplication of effort. It is, we each have our silo of information and responsibilities, and that's what we're trying to fulfill.
And I appreciate that you're working within that silo. I'm just saying, I'm not seeing the necessity of talking about duplication here.
Representative Ruiz.
Thank you, Madam Chair. Senator Petty asked all my questions. Thank you.
Thank you, committee. Are there other questions for the Medicaid Inspector General? Seeing none, thank you so much for being here.
Thank you.
Patient is Janet Williams, and she's with Minds Matter.
Good morning. How is everybody? Senator Gossage, I really appreciate you inviting me here today. We had a great conversation about the brain injury waiver. And what we discussed is there are many people who don't know about the brain injury waiver and don't understand the waiver because there are so many new people on this committee. So you asked me to come and talk for 5 minutes about that. So the brain injury waiver, who qualifies? It used to be only people with a traumatic car wreck, motorcycle, gunshot, caused from the outside. 2019, the definition was changed for internal. So now it's stroke, brain tumor, and the age range was also changed from birth to 65. So you can see that there's been an expansion of this program, and you're all saying, oh no, that's a lot of money. No, that's a lot of savings, because every person who comes on this waiver is saving the state of Kansas money. To qualify for this waiver, you have to qualify to go to what's called a brain injury rehab facility. The cost of that is $1,500 per day. The cost in the community is $100 per day. The brain injury rehab facility is automatically funded because it is state plan service. A waiver can have a waiting list because the legislature needs to fund it. Every year, we have to come and beg for money for the community side to get people home. So what do you get when you're, how do you qualify to get on the brain injury waiver? You have to have Social Security disability, which means that's a federal process, and you have to prove that you're not going to be working a year from now. It's a pretty strict guideline. I know more people who get denied than I know get approved the first time around, and so we help people with that. They also have to qualify for Medicaid, and many of you know you can only have $2,500 in resources, own a car, a house. Usually you lose your house in the process of a brain injury, because if you have a mortgage and your disability doesn't cover it, or you're in the hospital or in rehab or incapacitated for any length of time, you're going to lose your house. So usually people are working on selling it, freeing up cash so you can continue to get your medical assistance. The services people get, Kansas was the first in the country to have this waiver. It was 1991. You get physical therapy, occupational therapy, speech therapy, cognitive therapy, and behavioral therapy. It's quite a constellation of services. The average amount of time for us, for people on the brain injury waiver, is 2 years. So you say, what happens after 2 years? After 2 years, a vast majority of people are needing far fewer services. They don't need therapy anymore. They've also decreased the amount of personal care attendant or direct care workers they need. They can then transition to another waiver, whether it be PD, FE, IDD. We really try to get people to go to the work program so that they have a job and they can still get Medicaid until their benefits kick in with their employer. And so the goal is to get people off the waiver, get people off of Medicaid. It's rehabilitation. We're in there working on goals. The other beautiful thing about this program is the state does not pay rent. We don't have group homes. There are no congregate settings. There are no apartments with video cameras that the state is paying for. Everybody's in their own home. So we're helping people find housing, be in their own home, and get what they need. So then, when they become independent, they don't need us anymore. And that's what we talk to everybody we work with about. We've been around for 35 years. We're in all 105 counties. We currently have 193 employees, and we're providing more than half of the services to people on the brain injury waiver currently. It's a little over 1,000 people. We're at 500 and some. Last year, we helped 35 people get jobs. You don't hear that a lot, and they're not sheltered workshop jobs. They're not supported jobs. They're jobs in the community where people are working. They're usually on the Working Healthy program or something like that. We helped 122 people leave facilities. We hire physical, occupational, speech, cognitive, and behavioral therapists. For those of you who understand healthcare these days, to be a physical therapist or an occupational therapist, it is now a doctorate level. So we're competing with KU, we're in Rockhurst, we're in all the schools hiring people, and we are, and you have to have a master's degree to be a speech therapist. So today, the last two things that I want to say, we are asking for you to recommend out of this committee that the governor's recommendation for $719,000 to avoid a waiting list is funded. That's the cost of 1.5 people at the BRF for a year.
I'm sorry, Janet. We do have your written
Yes, you
testimony.
do.
We are giving everyone 5 minutes.
And the other piece in there is rates. So if those two recommendations could come out of this committee, we'd greatly appreciate it.
And if you could stand a moment
Sure.
for questions.
Absolutely.
Committee, are there questions for Janet Williams? Okay.
All right, you have a question, if you can just finish the 719 funded, and what was the other part you had before?
So 700, the cost in the brain injury rehab facility is $551,000.
Okay.
The governor is asking for $719,000 for the waiver. That will fund about 60 people on the waiver for one person in the community. And it's not about funding those people because, as I said, people go on and off. It's raising the threshold so more people can be coming on and off.
And my last question would be, how do people, I mean, I know they may have accidents or have a stroke, but how do they get in touch with you?
Well, we've been around for 35 years. We get about 60 referrals a month, so we start walking them through the process at that point. They also come through the ADRC. They come through KDADS. They come through each MCO.
Okay, fine. Thank you, Madam Chair.
Senator Petty.
Thank you. And since I'm not on the House side, and the House did just pass a budget,
Yes.
is this in there?
A slight rate increase is in there. We need more. And they did not take the governor's recommendation for the waiting list. We really need that.
Thank you. And you mentioned this, but I'm for those that maybe weren't here a few years ago, when we made this change for the brain injury waiver, I know that was a discussion when we went to being birthed to 65, that we would see an expansion of those that would be using the brain injury waiver.
Yes.
And so percentage-wise, what has been the increase that we've seen since then?
So there were about 250 people on the brain injury waiver when it was traumatic. It's now a little over 1,000, which is a great thing. Our referrals went from about 15 a month to 60 a month. People are finding out about it. They don't have to live in nursing homes. They don't have to, go to institutions, group homes, those kinds of things. So it is helping people become independent in their own home.
And I'll just give a little plug here because I unfortunately had a grandson, he has recovered, but who had a severe brain injury due to an accident 3 years ago now. So it is so critical that those services are available early because it can make life-changing alterations.
Life-changing. And we don't want people sitting in a facility for $1,500 a day when we know it's $100 a day in the community, and the only thing holding it back is the waiting list. And this program's never had a waiting list. We don't want the same thing to happen here that happened on IDD.
Thank you, Madam Chair.
Representative Sutton.
Thank you, Madam Chair. This may be a new guy question here. You mentioned rates. Weren't those just set? What is it you're looking for? I
The
didn't catch
therapy
that part.
rate. So for therapy, Kansas has the lowest in the country. It's $75 an hour. Out of that, we have to pay everything. Drive time, mileage, a doctorate level physical therapist, all of the benefits, and a ton of training in brain injury. So it's 75 in Kansas, it's 120 in Missouri. The national average is 140.
Excellent. All right, thank you. Thank you, Madam Chair.
Committee, thank you. We also have, thank you very much.
Thank you.
We also have Eric Hyde, who is with the Brain Injury Advisory Board. We have his written testimony. Eric, welcome to committee.
Yes, thank you. I'll try to keep my comments short. I really appreciate the opportunity to speak here. Ma'am, Senator Beverly Gossage. My mother's name is Beverly, so that's pretty awesome. Anyway, without the charisma and all that stuff, what I'm going to say here today is not going to be the greatest thing to hear, but I'm just going to say it anyway, okay? So I'm Eric B. Hyde, critical TBI survivor. 31 years ago, I was hit by a car in Lawrence, Kansas, March 16th, 1994. 16-day coma. My whole life has been recovery, all that stuff. I'm a current Lawrence City Commission candidate. I'm non-party, so I don't like taking sides. Anyway, I'm here to call out hypocrisy. Institutions that claim to help people recover do the opposite. They trap them in dependency. I see it everywhere. And I'll leave out that stuff. That's defrauding. The system isn't broken. It's designed to keep people stuck. KanCare, not really so much KanCare, but KanCare and subcontractors, such as traumatic brain injury rehabilitation companies, are not focused on helping people exit care like they say they are. They exist to maximize billable hours. The system is built upon institutional bias, cowardice, and prejudice. Keeping people dependent is more profitable than setting them free like they claim to be trying to do. Setting them free, that is. Those same types of subcontractors exist to exploit the very people they claim to serve. I know. I used to work for one of these companies. I don't want to call out the name of the company, but maybe we could get that inferred by me talking. I used to work for them. What they do is it goes kind of like this. They pathologize, they dogmatize, they medicate, they encourage medication, and then they manage, and then they say stuff like this. Oh, and how much money will I make this month? Oh, that's not enough. More. We need more consumers. This is kind of the stuff that goes through their mind. KanCare must be restructured to measure success by actual recovery, not enrollment numbers. Actual recovery means empowering people to terminate services, not lock them in care. And I know they say that they aim for people to terminate services, but it's simply not true. I used to work for these companies. They say it, but they do not mean it. Anyway, it's very frustrating. In third-party profiteering, no more companies making a living off keeping people sick. The choice is now stop funding providers based on patient enrollment, fund them based on real recovery outcomes. End financial incentives for keeping people in services of deception. We all know what's going on, so stop it. No more billing people for care they do not need. Hold providers accountable. If a program keeps adding more consumers, it should be defunded or restructured to stop consuming the consumers. No more empty promises. Real action is needed now. KanCare must stop trapping people in dependency. We must prioritize true recovery, not the survival of the false system. And here's the good news. If my claims are initiated in this current economic cycle, the things I'm recommending, KanCare will experience its own recovery like I've experienced. 2, it will free itself from the very leeches who say they care. That means more money for the right reasons, for the right people. And I know that came across kind of like stern, but I've been going through this type of stuff for 31 years. I've been exploited, abused, neglected, all this stuff by people who are claiming to help me. And I know I get it. I get that that's what they think in their minds that they're doing, but the simple fact is their words do not match their actions. So anyway, I just want to say that I'm very grateful to be here. This is like a very special moment in my life because I've gone through a lot of stuff. I've recovered on my own without the assistance of people helping me. And that's what I want to encourage today is self-reliance and like morality programs and stuff like that. Maybe there's a way KanCare can look at that type of stuff. Thank you.
Eric, would you stand for questions?
Yes, I would.
Are there any questions for Eric? And Representative Sutton, you need to go.
I do. Thank you, Madam Chair, and I apologize to the committee. I'm double booked this morning with the Healthcare Commission, so I apologize. Next meeting, I will be here the entire time, I assure you.
And I also serve on that commission, so I'll be going there after this. Thank you so much for going. Committee, other questions? Any questions? All right, seeing none. Eric, thank you so much for being here. Committee, we are going to move to KDHE updates and quarterly reports, and we'll start with Christine Osterland.
Good morning, members of the committee. I'm Christine Osterland, Deputy Secretary for Agency Integration and the State Medicaid Director. Happy to be here this morning. Madam Chair, before I begin, I'm covering a series of topics this morning in my update. So do you want to stop after each topic and ask questions, or have me go through the entire thing and go back?
I think it's better to stop after each topic. People tend to forget what questions they were going to ask. Thank you for offering.
Yep. All right. So if we go to, well, slide 2 is just what I'm going to cover today, the updates I'm going to give. But if we go to slide 3, that's where the presentation starts. A little bit about KanCare 3.0 and the implementation of the MCOs on January 1st of this year. So a little bit of background, KanCare 3.0, I know we've talked to Bethel before, but I know we have some new members. The areas of focus for KDHE and KDADS under the new contract was tightening up care coordination, focusing on access to care and services for our members, maternal and infant health, what's referred to as social determinants of health, and what we mean by that is the MCOs have requirements to reinvest some of their profits into the communities to support these needs, strengthening requirements for health screenings to try to treat the whole person, and then ensure quality of health and health care across all populations, trying to reduce health disparities, whether that be economic, whether that be I live in an urban area versus a frontier county, but really dealing with health care across all populations. The next one was the question around what did KanCare 3.0 cost the state? Currently, KanCare 3.0 did not cost the state any additional dollars, and I know that sounds kind of counterintuitive. The reason being, the only element in KanCare 3.0 that had a significant net new fiscal impact to the state was what we refer to as community care coordination. In the rates submitted by the MCOs as part of that bid, we got a range from the MCOs that would cost $20 to $25 million to implement. That program has not been implemented. It's a very new initiative, and so KDADS, KDHE, and the MCOs are meeting. Implementation is projected to be January 1 of 2026. So again, the question becomes, then why did the 2025 rates go up? So the increases to the 2025 rates are related to our actuarial rate setting process. So per CMS guidelines, and I did put the reference here to the Code of Federal Regulations, there's a series of have-tos for the state as part of the actuarial rate setting process. And then there's also national standards and guidelines that actuaries have to abide by when they do rates. So essentially, the rate increase would have been the same if KanCare 2.0 would have continued or we went to 3.0. What we would have had to have done if 2.0 was still going is we would have had to amend those contracts to account for the changes. So again, the fiscal impact of 3.0 is yet to be realized for the state, and it will probably be first of next year. When we talk about changes to the KanCare program in 3.0, a lot of those were non-rate impacting changes. So we did things like clarified standards around non-emergency medical transportation. We put in more specific so we could hold the MCOs accountable for their performance. We put in things like they had to actually define their ratios of care coordination to care coordinators to population so we could hold them accountable. None of those are net new cost to KanCare, but they are getting at ensuring that the MCOs are doing what the state intended them to do. So most of our changes were not rate impactful, like I said, besides community care coordination. Next slide. So again, on January 1, 2025, Healthy Blue went live. They actually paid their first point-of-sale pharmacy claim at 2 a.m. on January 1st. Healthy Blue actually met network adequacy standards 2 months prior to go live, which was good because, again, that gave us assurance that they were ready to go. One of the things that Healthy Blue did prior to go live is they set up emergency escalation paths for key providers, hospitals, HCBS providers, nursing homes, some of those real key providers. So if something was going wrong or they had questions or for some reason they were having any issues, they had an immediate and open line of communication with Healthy Blue. You'll see that later that Aetna did the same. Healthy Blue and KDHE, as we went live, we set up daily meetings. Every afternoon we met from 4 to 4:30 to talk through the day's activities, looking at claims payment. Obviously the first few days, because there weren't medical claims submitted, it was primarily looking at pharmacy data, but to talk through if there were any issues uncovered. We also had throughout the day an open Teams channel set up. So again, if there was an emergency issue that came up, KDHE and Healthy Blue had real-time communication. Happy to report that by the time we got to the end of January, Healthy Blue was stable enough that we were able to move those meetings from weekly to 3 times a week. And I'm happy to report as we end February, we are now down to once a week. As the medical claims, next slide, please. As the medical claims started coming in, they were a little delayed. A lot of that was, if you all remember, we had the snowstorm across Kansas in the second week of January, which again delayed some of the, some of those provider offices were closed. So we did see a little bit of delay before claims started coming in. But Healthy Blue made a decision prior to go live to process claims in small batches. So if they had, claims that were in like HCBS claims, they would process them in small batches. They would watch them go through the process. So if there was any issues or barriers, they could be identified and corrected before they started doing what we call auto adjudication. So they followed this process. So again, any issues could be identified and corrected. They could work with those small groups of providers. It didn't delay payment to the providers, but it ensured that they were paying claims and processing claims accurately. And in hindsight, that was a very good strategy by Healthy Blue. Later in this slide, you're going to see just some claims. Of course, this is as of February 13th, so this data is already out of date. But as of February 13th, they had processed 82,127 medical claims, resulting in $27 million in paid claims to providers across the state. Next slide. Next slide is a little look at pharmacy. This again was as of the end of January, so this is even a little bit older data, but as of the end of January, they had processed 133,186 pharmacy claims for $11.7 million in paid claims. Throughout, since go live, as we've been working with Healthy Blue, their paid, denied, and rejected claims have all been within expected thresholds, which was again good news. And again, Healthy Blue continues to closely monitor pharmacy claims, so if any issues are identified, they can reach out to those pharmacies directly and handle those. Next slide. Next slide is call center performance for Healthy Blue. Again, both their provider and member call centers continue to perform very strongly. You'll see here that on the member side, as of February 13th, they had almost 11,600 calls that had come into the member call center, and a little over 4,400 calls that came in on the provider line. Abandonment call rate remains below 1%, and that continues even now. And again, just listed some of the most common reasons people call. Members are calling around their benefits, ID cards, or trying to find a provider. On the provider side, they're calling about benefits, authorizations, prior authorizations, both new or existing, and eligibility of members. Next slide. Of course, part of our implementation was the transition of Aetna out of the state of Kansas. I know Aetna made a commitment to the Bethell Committee that they would be a good partner to the state of Kansas as they exited, and I'm very pleased to report that they have followed through on that process, on that promise. They have been very collaborative and cooperative with not only KDHE and KDADS, but also with the three ongoing MCOs. Again, we now are conducting still weekly meetings with Aetna. We're receiving weekly data. You know, we did recognize that in the last transition, managed care transition in Kansas, there were a lot of issues around claims payment for our provider community. So we stayed in close contact with Aetna. Again, I'm happy to report, they continue to pay claims. You can see some of the numbers here. In the week of January 12th, they had processed over 51,000, almost 52,000 claims. Of course, that number is now decreasing week over week, which you would expect. But again, we're seeing rejected claims average 2.41% a week, which is well within normal expectations. And again, if you look at appeals and grievances from both providers and members, they remain very low and within expected standards. So again, we continue and will continue to meet with Aetna weekly and get weekly data from them for several months. But all early indications are Aetna has done an excellent job of transitioning out of the state and making sure that they keep their commitment to our providers by paying the claims that are due. And with that, that's kind of an overview of what's happened since January 1, and I'll be happy to stand for questions about the MCO implementation.
Committee, are there questions for Christine? Representative Bryce.
Thank you, Madam Chair. Thank you, Christine. Good to see you. You had mentioned initially about the actuarial changes that came down and there was an increase in rate. I was just curious about that. That's related to an expected increase in services? Is that related to average age increase of the clients or morbidity increases? Or do you have any data on the underlying cause? Thank you.
I am not an actuary, so I can provide you high level what goes into rate setting, but it's a little bit of all of the above. So when an actuary goes to set rates, they are going to look at, what services are being provided. Are there any new services being offered? Any rate increases? So as the legislature, which has done a lot of great work in the last couple years of increasing rates, then that will impact rate setting. They're going to look at acuity of the membership. So again, Medicaid membership ebbs and flows. And so some rate setting periods you may have higher acuity, which means your members are sicker as a whole. That's going to impact your rates. They're going to look at utilization of services. Again, that mix of utilization changes over rate period to rate period. They have to include medical inflation. So again, I know people wonder why they're going to go up year after year, even if there's a lot of constants, because you have to, by CMS regulation as well as actuarial guidance, you have to include medical inflation. So there's a lot of factors that go into rate setting, that it is a very complicated science. Actuaries are licensed, and so for them to sign off and certify our rates, they're certifying that they followed all of the not only federal guidance from CMS, but also actuarial standards. And then when those rates go to CMS, their actuaries will review them and ensure that all of those protocols were followed. So it's a very prescribed process, and states don't, we don't have a lot of wiggle room, so to speak. It's a process. This is how you follow it. But we are required to submit those rates annually.
Thank you, Madam Chair.
Additional questions, committee? I have a question. What is the capitation rate this year? The per person or per member per month rate that is paid to the MCOs?
So it varies by rate cell. And there are, and I can follow up with the committee and kind of give you an overview of the rate cells and kind of like what the average is, but it varies greatly. So for example, an IDD member on the IDD waiver, their per member per month cost is going to be somewhere between $7,000 and $8,000 a month for that member, versus a healthy child, which is going to be less than $500. So there is great variety in rate cells, and rate cells are by program, ages. So again, there are lots of factors. Like I know we had a question last time around the dual eligibles, and if you in the written testimony, you'll see how many rate cells apply just to dual eligibles, and I think it was 68. I might be a little bit wrong, but it was a large number of rate cells just for the dual eligible population. So again, I can get you like the total number and then what the overall average is. But the average will be a little bit misleading because there's such a vast difference between our more expensive populations and then our, healthy children or healthy caretakers.
So then when an individual is assigned to or the individual chooses one of the MCOs, you already know these health conditions, and so the capitation rate is already determined? Or is it only after they've had the individual, they've conducted some kind of a survey of their health, or the doctor's done a thorough checkup before they know, hey, this person has XYZ, therefore the MCO should be paid XYZ?
So rates lag. So when we're setting rates, we're looking at previous years' claims data, so it isn't real time. So we're looking at claims payment, we get all the encounter datas, we're looking at acuity, we're looking at those things, but it's retrospective. So what I'm paying the MCOs today for a rate cell is going to be looking backwards at what happened 2 years ago. Now, with that being said, if we implemented a new model of care, let's say when we implemented the CCBHC model, then you would try to do a little bit of math and, estimations of, because this payment structure is very different than the previous model, what is that temporary adjustment we're going to do to account for that? I will say Kansas is generally very conservative in making those estimates, because what we don't want to end up in a situation of is overpaying and then having to make that up later. What you will see a lot in Kansas, like around the CCBHCs, is that, we will set rates and then we'll do an adjustment later to account for the fact that the experience was more than what the rate accounted for. But we're always looking backwards to set rates for today, if that makes sense.
It does make sense. And I guess my last question is, so I'm an MCO. There's a certain rate for a 7-year-old that comes under us for Medicaid. And we receive whatever that cell rate is or whatever you had determined that a 7-year-old should receive. And then going into this, we discover that this 7-year-old has a lot more health issues than most 7-year-olds. Then can they come back and request additional dollars for this individual child?
So they really can't necessarily come back and ask for additional dollars, but one thing that we do as part of rate setting is look at acuity. So what you'll see is it's not so much at the individual level, but what you will see, again, each of our MCOs have different memberships. So MCO A may have overall a sicker population. Maybe they have more IDD members enrolled. Maybe they have more of our nursing home members enrolled. Maybe they have more of our high needs children enrolled compared to MCO B. And so there will be so-called an acuity adjustment, or some people might call it a risk adjustment. But you'll try to account for that on the aggregate in your rate setting. So you may have an MCO that will get a little bit of a bump payment, if you will, but it's accounting for that acuity of their membership, because it is not the same from MCO to MCO.
Thank you very much. I would like to see the cell rate and how that's determined. Thank you so much. Any other questions, committee? Seeing none, you may proceed.
Senator Petty had a question.
Apologize, Senator Petty.
This is just a follow-up to what you just asked. So when you talk about that acuity rate, so and you're talking about the population for each of the MCOs, is that acuity rate put on the cells at the time you're figuring it, or is it put on after? I don't know if I'm making sense.
So, yeah, so the adjustment will be done, but again, it's not being done on real-time experience. It's kind of still being done based on, older data, if you will, the most recent data.
Whatever data is available for that.
Yeah.
That cell,
Yeah.
Okay,
Yes.
thank you.
All right, so now we're going on to the KDHE rate study, which we have been doing now for about a year. So I do want to say that if folks are interested, we do have both the rate study for what's called evaluation and management codes posted, as well as dental rates. So again, the rate study looked at the fee-for-service rates, or the fee schedule rates for Kansas Medicaid, comparing us to Colorado, Iowa, Missouri, and Nebraska, as well as when applicable, Medicare rates. You will see in the published results that we may cover a code in Kansas that maybe Nebraska doesn't cover, or Medicare doesn't, cover that code. So again, there are variations, but we do have those posted. We in-house have radiology codes. We're in the final phases of formatting those, and then those will go on the website. Next slide. What I really wanted to focus on today is what we're learning as a result of this rate study. So it has actually been, I think, a very good endeavor that we did. So we are seeing that we already have codes where we can see that our managed care plans are paying above, on average, our Medicaid fee schedule. So to give an example of that is if our fee schedule for a particular, I'll use dental because that was the first one we did, for a dental code was $19.80, when we look at MCO data, we can tell that on average, they're paying, let's say, $23 for that same service. What that means is our managed care plans, in order to have an adequate network, are having to negotiate with providers to pay a higher rate. Doesn't mean that they're paying that rate to every provider. So it's opened up a whole nother door for us of things that we're going to need to look at as we finish this rate study is really, we've reached out to the MCOs. We've kind of talked about areas where they see this most commonly, where they're having to pay above our fee schedule. And so to kind of put that back into our rate discussion, rates will account over time for what the MCOs are paying, but initially it will be based on our fee schedule. So like for Healthy Blue, if they're having to pay a lot of providers above the fee schedule, it puts some pressure on them financially. So again, we're going to be digging into this more, but I did want to let you know that we are seeing some codes where, again, just to have network adequacy, our MCOs are already paying above our rates, and those might be areas that the legislature might really want to look at. The other thing that impacts is, depending, me as an individual provider, for instance, let's say I'm not a math person, so I like to work in easy numbers. So let's say the fee-for-service rate is $100 and I've negotiated a rate of $105. It's going to depend on how my contract is structured. So if you did a rate increase of $7, depending on my contract with the MCO, my contract may say my rate automatically stays 5% above. So if we raise the rate, they are still going to get 5% more. My contract may not say that, so I may only move from $105 to $107. Again, that's all going to depend on those arrangements. So different providers could be impacted differently by rate increases. If I'm a provider getting paid at the fee schedule, obviously I'm going to see, the full impact of the bump. The other thing that we've learned from our rate study is some states have alternative payment methodologies around some of these codes. We're seeing this a lot in non-emergency transportation. Again, will be more research for KDHE to do of, will some of these alternative payment methodologies, could they be applicable to Kansas? Could they help us other than just coming and asking for rate increases, which we know is an impact to the state budget? Are there alternative payment methodologies that may help our providers, but also not be such an impact on state general funds? So more to come on that. So again, we've learned a lot in this rate study. I think we're going to ask that we conduct this probably every 3 to 5 years, because I think it will be important for us to keep up on these emerging trends and understand what's happening and be able to make really good recommendations to the legislature around rates and where gaps are and where we're seeing maybe the MCOs already having to pay more money than the fee schedule. So with that, I'll stop on the rate study and be happy to answer any questions.
Questions, committee. Representative Bryce.
Thank you, Madam Chair. Thank you, Christine. Just a quick question. I'm thinking about what you said about the rates and what goes into determining the rates. Obviously, there are different situations that could be less expensive. For instance, a emergency room visit is a higher cost than, say, a primary care doctor, or a tertiary care visit might get you more expensive evaluation than a rural hospital, say. Does the Medicaid program or the MCOs, do they have any incentive programs or marketing or information for clients that push them toward the less expensive alternatives, primary care rather than emergency room, et cetera, in order to save expenses on that end?
So
thank you.
I'll answer from our perspective, and then I think that's also a great question to ask the MCOs when they come up here. But from a state level perspective, that's the whole concept around care coordination, is keeping the population healthier, keeping them directed into going to their primary care visits, receiving their care in the least expensive most beneficial many times setting. But yes, I am aware that our MCOs, do a lot of work around kind of that best level of care, and having folks not, what we don't want is you don't want a member showing up in the emergency room and that's kind of their primary care, so to speak. We know that does happen at times, but again, I know the MCOs have a lot of programs around getting them into that more consistent care and either avoiding the need for an emergency room because I'm having an emergency episode because I'm better managing my health, but also to the point that I'm maybe being, I'm learning about the healthcare system and the fact that, it's better to get my care in this other setting than, showing up at the emergency room because I may believe that that's all that's available to me.
Madam Chair, just one quick, as an emergency room doctor, I can tell you from my experience that we have an avalanche of Medicaid patients that use the emergency room for primary care, even prescription refills and so forth. And I just think that maybe it's a question for the MCOs, but how can we provide information, education for the clients, or even incentives of other kinds for the clients? It just seems like a huge potential cost savings. So thank you.
Yes, agree.
Additional questions, committee? Senator Petty.
Thank you, Madam Chair. So you mentioned with the rate study how valuable it's been. When was the last time that we did do a rate study?
It was the best we could tell, like 2017. So yeah, it was quite a while ago.
Okay, and it does sound like it's probably a good idea for every 3 to 5 years. When you mentioned about having to pay above the rate that's being provided to the MCOs, is that, will that, with the rate study, will that also show, like, I would think in a metropolitan area, if you wanted to have more than one provider that was available, I know we've often talked about, like, for pediatricians, that we have a shortage anyway, but that we have a shortage of pediatricians that are participating with Medicaid. So does that help to not only bring forth a shortage, but also that they can only find one provider that will take those rates?
So I think the answer is going to be a lot of a mix. We've really started digging into looking at who is receiving the higher rates as far as providers. So we are seeing a variety of things happening. We're seeing in some situations where it is a rural provider, they may be the only one that provides that service, and so they kind of have some probably negotiating power with the MCOs. But we're also seeing in urban areas, especially very large practices, that are probably more skilled at negotiating. There's also, again, providers where we just don't have a lot anywhere in the state. But it's really an answer of all of the above. There's a variety of reasons, and it's interesting as we dig into more on a code-by-code level of seeing the variety of who's getting the higher rate. And again, that would be proprietary, information, but it is information that we can see. But we're going to be providing feedback to you more on the aggregate level of, like which codes we're seeing, them having to pay a lot more in the rural or frontier areas, which provider types. It's all of the above, which ones it may be more on a specialty by specialty basis. So, a lot more to come, but it has been a very eye-opening study, if you will.
Thank you. And I just have one follow-up, and that's dealing with the non-emergency transportation. So does providing, like some of the MCOs have added services where they've provided transportation, like to doctor's appointments, or does that fall into that non-emergency?
Yes, that's non-emergency. That would be, yes, appointments to, transportation to medical appointments, doctor's offices, you know, and the like, therapy offices and such. But yeah, that's what non-emergency transportation is.
Thank you.
Representative Ballard.
Thank you. I want to follow up on that. I think from what I see, you have, what, 30 counties that you were looking at in your study, right?
So for the rate study, for the TMAW grant, when we get to that, yes, that's restrictive. On the rate study, it was every code that we have that's on our fee schedule.
Maybe I'm ahead of.
Yes, you are ahead, but
Okay.
yes.
So I'll wait because I want to
Yes.
talk about the 3 areas.
Yep.
Okay.
That's all the question. Oh, wait a minute. I believe that Representative Ruiz is on WebEx, I'm told.
Yeah, thank you, Madam Chair. Secretary, with folks utilizing the ER more often than, of course, anyone would like, and even for primary care to get medication, is that also due to the fact that we have such a shortage of physicians that we'll see, we have a shortage of physicians, period, but do we also have a shortage of physicians that can see adults and children with Medicaid?
Yeah, and I think that would definitely be, part of it. I think, again, our healthcare environment is getting complex, but again, it could be that you're in an area where there's a lack of a certain provider type, and so it's hard to get, appointments. We do have standards in the contract to try to help with that, but if you have a workforce shortage in that area, obviously, you can't just, create doctors. So I think that's part of it. I think some of it comes down to, some of the transportation, issues that, members have. They may be employed, and so to try to take off work to take myself or my child, when I can just show up in the emergency room on a Saturday morning when maybe it's more convenient for me. So I think there's a variety of reasons of why that does occur. But yes, workforce availability would be a part of it.
I've had to go to urgent care 3 times within the last 2 months because I can't get in to see my own doctor.
Yep.
Thank you.
You may
All right.
proceed.
Okay, so the next item I'm going to talk about is in December, Kansas was awarded what is called, people call it the TMAW grant, but it's a maternal health grant through the federal government. It's a 10-year, $17 million grant. The premise of the grant was for any applicant, so they did 15 awards across the country, and what they asked of each state that was going to apply, you had to have a pilot area where you were going to implement your payment methodologies and your strategies for the grant, and then you had to compare that to another area of the state where you weren't doing all of this work. So you kind of have your test region, if you will, comparing it to another area of the state. The grant did require that you focus on areas of the state that have what they call health professional shortage areas. They were really interested in rural areas, areas with already kind of defined health outcomes that are less in compared to other areas. So there was requirements in the grant for us to define what these areas would be. So again, we've got our test region, which is 30 counties in southwest and central Kansas. And they're going to be compared to another county region that's in northwest and central Kansas. Next slide. The nice thing about this grant, which is why it made it really encouraging to Kansas, is because of the longevity of it, it's 10 years, but you get money for infrastructure, you get money for alternative payment methodologies, so there's a lot of it's kind of the whole picture, if you will, because sometimes to implement a new payment methodology, you have to have some system support in place to be able to do that. And this grant not only looks at the delivery of care and the practitioner and member side, but also what the state would need to be able to put this in place. So again, because it is a 10-year grant, obviously it will happen in a variety of stages. I won't read all this slide to you, but you can see some of our key timelines of what will happen at the end of, year 2 and year 3. Really, by the time that we get to end of year 4, that's when we'll really start to see, hopefully, some of the outcomes and improvements and some of the data that I know folks will, really be interested in. And another key component of this is growing the workforce. Hence our last conversation, especially around some of those support workforces. So again, we're excited about this grant. We were notified right before the holidays, and so the last 2 months as we've really been engaging with our partners up at CMS. Right now we're doing what I call a lot of the foundation of getting all the reporting and all of our have-tos with the government in place. We're creating the positions, some of that foundational work, but we're hoping as we hit about April that we'll be ready and in a position to actually start working on the activities of the grant. So with that, I will be happy to answer questions.
Representative Ballard.
Thank you, Madam Chair. Well, first of all, I want to say congratulations to get a $17 million grant. We hear a lot about the agencies, how much money the state has given you, but we rarely have an opportunity to say what the agency did in order to bring in $17 million. And that's a lot of work. I mean, I write grants, and grants are not easy, and they continue to require things. So that is really good on behalf of the state of Kansas. Now, you have those 30 counties, and what I see here is 20 of those counties are what you would call deficient or in need, special need of primary care, dental, and mental health, okay? Yeah. And so those are the 3 areas that we focus on. I serve on social services, budget, and those are big areas, especially in rural areas. And now it's even in urban areas. So if we're having problems in an urban area, you're really going to have a thing. So you're going to do it in stages, am I correct?
Yes.
So are you going to try to hit all 3 at the same time, or will you focus on one to bring that up, then go to the other? How was that grant structured?
So it'll, again, it'll be a little bit of everything. So one of the big components of this grant will be telehealth. And how do we use telehealth to support these, especially maybe our primary care and our mental health? So those may happen more, simultaneously because they're services that lend themselves to that technology. The ones where they are more, what I would say, location dependent, you have to actually have, obviously, in many cases, you need to have a dentist, present. Those types of services will take a longer strategy and more work and probably some creative payment methodologies, because one of the idea is, could you under the grant and under an alternative payment methodology, could you encourage a dentist that, like for instance in Kansas, that might be in one of the Kansas City suburbs, would they be interested if there was some type of other payment methodology to travel to one of these counties and do, a day a month or, so that's the flexibility this allows us, is to think maybe outside the box, things that in the Medicaid program, to be frank, is very hard to do because of all the rules we have from the federal government. So it really gives us a lot of flexibility to be creative, look at different ways of, doing business, if you will. And then if we can demonstrate success in that, then that's things that we can bring back to the legislature of, like, is this something we'd want to consider in other areas? And to your point, Representative, when you talked about the focus of the legislature, this is why this grant was so appealing to KDHE, because this legislature has done so much work around mental health, dental, the 12-month postpartum continuous coverage. You've done so much work in this area to kind of lay the foundation that, to me, this is a great grant to kind of now put on top of all that and see what we can do to get the outcomes that I know you want when you pass rate increases or you increase services. But this grant, I think, will give us that opportunity to really see how far we can take what you've built and now add on top of it to make a robust system and hopefully show the outcomes that we think will show at the end of it.
I think so. And Madam Chair, I was very excited about that because it is like continuing
Yes.
what we have started. Also, we have heard where we could save 25 million, maybe recapture that because of what was going on. In this case, KDHE has a cost savings of 17 million that your grant brought to the state. And often we hear about where the deficits are, but we don't hear about what has happened here. But this is 17 million that the state is not paying for. The federal government is, but you have all the requirements that you have to fulfill. So again, thank you very much.
You're welcome.
Committee, I'm sorry to cut off questions, but we're behind schedule, so we'll go ahead and move on with the
Okay,
Medicaid
and I'll-
eligibility.
Yep, and I think this is really my last update, so I will try to go quickly here. So if you go to slide 14, so I will just do a little highlight. January was an interesting month. As you know, the first week of January, we had the 2 snow days for winter, which means the clearinghouse was unexpectedly shut down. We had the National Day of Mourning. And then the following week, our vendor had a nationwide outage in their system for 3 days. So we essentially lost 6 days of processing, 6 days of really the call center being able to function in the state of January. So if you go to the next slide, so I will say that obviously that had a negative impact on our ability to process applications because we were essentially grounded, if you will. So right now we are at 1,990 applications over 45 days. This is actually down from coming out of January. We had hit a peak of just under 2,500, so the teams are working overtime. They're doing a lot of good work to bring those numbers down, and they continue to go down. They even dipped a little bit after we did this slide. To give you reference, because I know you don't live in these numbers like I do, typically when we're at Bethel, we're between 1,100 and 1,300, so we're not far off at this point of being back to normal. But again, you know, we don't like the disruption for our members because obviously anybody that's trying to complete a review or application, that's very stressful when unexpectedly we're not available. Next slide. You will also see it in the call center performance because on any given day, obviously we had pent-up demand from being shut down because of the weather. And then when this outage happened, we could, I will actually say kind of, you know, putting a little bit of bubble gum and duct tape, we were able to get about 10 agents taking calls. Now, to put that in perspective, we typically have 70 to 80. So again, call center performance, you see that represented for January, the impact of that. Happy to report February, we're back to our consistent numbers that you see. But January was a very interesting month for us, and I would care not to repeat it again. Couple things I want to highlight, I think really good news. In October of 2024, KanCare was able to implement a new fax system. So again, you'll see here that on average, we get 175,000 faxes. About 2 million pages a year. I'm sorry, I'm getting a little tickle in my throat, so I'm going to try to get through this. So really what was happening in the past is that these faxes would come in, they would have to be printed off, sorted, and then scanned back into our system. And yes, we were doing that up until October of 2024. So we implemented the new fax system, which now allows technology to take care of that, and the faxes will now go into our system unless there's some kind of glitch, which of course, you know, nothing is perfect. So big win for eligibility processing that will do a lot to also cut down on time because we're skipping a whole step of people having to manually touch these faxes. So again, very excited about that. On the next page, I had mentioned this proactive communication that we implemented in the summer. We continue to get positive feedback from our members. You can see we get approval ratings of 2.7 on a 3 scale. Proactive comms is a way for us to let our members know when they have a renewal due. Anything that we would need to communicate to them, we can do it over text or email if they've opted in, and again, is a way for them to, know when they need to respond or when their renewals are due. Next page. The other part about proactive comms is that one of the focuses of that is we've really tried to increase our numbers of our portal. So people can go into the portal, complete their reviews, upload documents, and not have to do fax or mail things in. And you can see here, this just logs the actual numbers of people that have accessed their online account. Seeing we were down just under 20,000, and then now we are up to over 38,000. The next page actually just puts it by percentage, but puts the marker in of when we started ProComs. And so it continues each time that we do a ProCom messaging around the portal, getting folks to use it. We continue to see bump up in our percentages and our numbers, which is what we want, because that's a much more streamlined way to get through the eligibility process and not rely on faxes and what I call snail mail. And with that, I'll stop. That's eligibility. If there's any questions.
Other questions, committee? Senator Petty.
Thank you so much for this information about the proactive communication. So just so I understand this, then you're seeing, so this is from January, excuse me, 24 through January 2025. So as you're sending out these online communications, you're seeing an uptick of the clients then also using the online responses?
So we're sending the messages out, primarily text, some email, but then yes, we're seeing the correlation that then they're going out to our portal and they're completing their renewal or uploading their documents, which is what we want, because that's the quickest path for those. If they use the portal, that automatically gets into the key system and it skips a few steps in the process. And so it gets them from I'm starting to I have a decision in a much quicker fashion. And again, a lot, no risk of, waiting on the mail, waiting for a worker to open the mail and get it in the system. So it really benefits our members and our workers, because it creates a lot of efficiencies that we don't have to have so many staff touching things multiple times to get it through the process.
And you still will have the renewal. We have a 12-month system in Kansas.
Yes.
So if I am a client and then my renewal, how soon out do I start getting notices that I have to renew within that 12-month period?
So our MCOs will start some communication usually about probably 60 days out. We start a ProCom communication, and then the renewal is mailed right around that time. The beauty of the portal is it's automatically available in the portal. So as soon as I get that message, I could log into the portal, complete my review, and within one day, that's in our system to be processed. We still will mail it, obviously, but again, it's a much quicker process for the member. If they've signed in for all electronic communication, then we can do everything through the portal, and that's a cost savings as well, because then we don't have to mail, information. We can just let them do it all electronically.
Thank you.
Additional questions, committee? Seeing none, thank you so much. And
Yep.
we appreciate you being with us.
Yes, thank you.
Committee, we will now turn our attention to our KDADS updates and Secretary Howard.
Thank you, Madam Chair. Secretary Howard, KDADS. I'll just do a quick kickoff for this before I hand this off to some of my deputy secretaries and commissioners to talk about the topics that you asked about. I just first wanted to just let this committee know that all of the annual reports that we were required to do as an agency, and we had about 15 or 16 annual reports. They are on our website, and we've submitted all those to the legislature. We're happy to speak about any of those at any time if you'd like more details about those. I also just wanted to make a mention of our legislative agenda this session. KDADS has had 4 bills that that we asked for introduction of this session that are at various stages in the process. The first one is really to put the mental health intervention team program in statute. You know, that program was transferred to KDADS last session by a very large budget proviso, and so I think that's currently in the House Health Committee, and we anticipate having an upcoming hearing. The second bill, and you'll hear a bit more about this from Deputy Secretary Bruner in terms of current progress. It's now time, with the work going on with the South Central Regional Mental Health Hospital, to make the necessary statutory changes, actually to name that hospital in statute, to establish catchment areas and make a couple tweaks in the statute. And we've seen that bill pass the House and moving on to the Senate. We also have some legislation we're interested in related to creating the ability for a civil monetary reinvestment program related to some of our licensed providers that would allow some of the revenues from fines or fees to be reinvested in quality care improvements with those providers. And again, that's also still early in the process. We hope to get some movement on that. And then the last one was a bill related to some of our forensic competency that would have the default position be that those forensic competencies be conducted on an outpatient basis. And again, we had agreed to introduce this bill as part of a settlement agreement we have related to wait times for forensic competency. So again, that was kind of our legislative agenda. On the next page, I just wanted to mention briefly a couple of our budget areas of budget focus. On page 3, I have the initial governor's budget recommendation. The House, of course, has now acted on the budget. It'll be on its way to the Senate. And we were grateful that from the governor's budget recommendations that there were a couple items that were funded in the House budget, particularly the second item, $2.5 million all funds, just under $1 million state funds to fund the first individuals on the community support waiver for the last quarter of next year, and also a little further down the chart, about $1 million related to nutrition services that was related to a federal cut that unexpectedly occurred after the budget process last year. So we were grateful to get those 2 items funded. But you'll see on the next page, there are some areas where we will continue to advocate through the rest of the session on a couple of priority areas in the budget. You actually heard a little bit about one of these from Janet Williams earlier. We have 3 HCBS waivers that don't currently have wait lists that have been experiencing significant growth, and we'd like to avert having wait lists on those waivers. And so we'll continue to be talking on the Senate side and also back on the House side as the session continues. Those are the frail elderly waiver is the largest funding amount. We've seen about a 7% increase in eligible participants over the last year, and it's really been a steady increase really since COVID. I think as we see more individuals, seeking to remain in their homes and in the community for longer periods rather than going into a facility. The funding the governor recommended that's not currently in the budget would offer those services to about 600 more seniors, and that's our estimate of really what the demand is based on the current growth line. There's also funding requested to avert a waiting list on the brain injury waiver, which again, part of the significance of that really relates to it being a rehabilitation waiver. It's really important to be able to start those services as soon as possible after that injury, whether it's traumatic or acquired injury. And then the third waiver we would like to avoid a waiting list on would be the technology-assisted waiver, which again, that's the waiver that provides services to kids who require life-saving medical technology. So again, we'll continue to advocate around those facets as the session goes on to really hope to not have waiting lists in those arenas. And then the other area that you'll continue to hear me talk about during the remainder of the session as well is some funding that would support HCBS providers through some of the transformations that are happening in that system. And I know you've all heard a lot about this. You continue to hear from constituents, and we continue to work with providers and families on this issue. In fact, we've got a series of, I think, 3 meetings starting up again next week with Interhab and many of their providers and families on the key focus areas. But I continue to believe that really to advance this forward and provide the kind of support that providers need for some of the transitions that will happen, that the funding that the governor had recommended to support those providers around the issues of kind of conflict of interest and provider expansion are really important. And I know the legislature has put has passed some legislation through both houses that would require some approval from the legislature and put some limitations on our ability to move forward. But again, many of these things, I mean, we do have to make changes. We're committed to working with the providers to find a pathway forward, and with families. There's no goal here to hurt individuals in receiving services. And I hope we'll be able to make that case to you and build your confidence as the session goes. But again, I think you'll continue to hear me ask for support, for some additional support for those providers for those changes. So again, actually had these down here a few weeks ago, and we thought we were going to be meeting earlier, but I thought I'd still take the chance to make that pitch a little bit. So that's really all I wanted to say this morning before I hand it off to my colleagues, but I'd happy to answer any questions if you'd like me to do that first.
Committee, any questions for Secretary Howard? Senator Petty.
Thank you. Thank you, Secretary Howard. So when it comes to HB 2236, can you remind me where it's at right now?
Which one is, okay. Yeah, I think that's in-house health. Yeah, I think that's in-house health. But I think I'm looking to my legislative liaison if that bill was blessed or not. Do we know if MHIT was? It's exempt. Yeah, it's an exempt bill based on where it was introduced. So we continue to expect to get a hearing. So.
Okay. So we'll expect to talk about it too.
Yes. And it is also still a budget proviso in House Bill 2007. So
it's a budget proviso.
It is a budget proviso, and this legislation would eliminate the need for a budget proviso to structure the bill, to structure it. So.
Thank you. And then on the HCBS waiver growth, that's when you talked about the 6.2 million, you're still working on it, that's not in the budget?
That's correct. For each of those 3 waivers, the 6.2 million on the FE, the 1.7 million on the technology assisted, and the 700,000 on the brain injury are not yet in the budget. So again, you'll continue to hear me advocate to avert those waiting lists. So
thank you.
Thank you. You may introduce your next speaker.
Thank you. Next, we will have Deputy Secretary Scott Bruner, and he'll be joining us on WebEx. I'll embarrass him a little bit. He's a new grandfather, and he just went to meet his grandchild, so he'll be joining us on WebEx.
Thanks, Secretary. Can you hear me okay?
Yes, we can.
Okay, thank you. Madam Chair, members of the committee, thanks for letting me connect remotely today. I just have a couple of updates on our hospital project in Wichita. You've got the slides in front of you. This is a unique project. We're working in partnership with Sedgwick County to actually construct the building that you've authorized through appropriation, and they've awarded the general contractor contract to Key Construction. They've been on site for a little over a month now, working on the site, getting it prepared. They've got the preliminary lift for the concrete pad that's going to be poured for the building. That's ready now. So we've made a lot of progress over the last month as we've been waiting to update all of you. The construction, like the slide says, started in February, and we're going to be complete by the end of October of 2026. We put a couple of comments in there about the funding for the project as well. And that's all that, again, the project's completely funded for the construction side with appropriations that you've all made over the past couple of years, an additional appropriation last year, and then spark funding as well. We have, through our memorandum of agreement with the county, we've transferred the first part of the spark funding to the county for construction. So the financing's been working well. The process for that's been working well also. We have appointed a couple of staff members to help with the project, even at this early phase. There's an acting superintendent that we've appointed that's working on a lot of the project coordination and other staffing and program development, and a facilities director that's based in Wichita that's actually helping oversee the construction parts of the project on the day-to-day. And then the secretary already mentioned the bill that we introduced, House Bill 2365, this session, that'll name the building, authorize it in statute, create it as a state agency, and then designate the catchment area as well. That's made it through the House now, and you'll expect to get it on the Senate side probably next week. It's important to get that done this year, this session, if possible, so we can set up the accounting structure, build the budget, give you the full operational picture as part of the budget cycle next year, and have some of those preliminary items complete. But the project's going well, and on the second slide, or the other slide, I just want to give you a little bit of an image of what the construction site looks like. It's a little bit old now, but if you're advancing to that, it's on my screen, but this is our construction sites at the corner of MacArthur and Meridian in South Wichita, and this looks kind of from the corner of our site to the west on MacArthur. Now there's rock and there's construction trailer and other things there, but we'll keep providing some images along the way. So for those of you that aren't from the Sedgwick County area, you can see kind of what the construction project process looks like as we're going forward in future quarters. And Madam Chair, that's all that I had for today. I'll stay on if you have questions that come up later. I'm happy to take a question now if that's appropriate.
Committee, any questions for Scott and Bruno? Seeing none, thank you, Scott, and congratulations, Grandpa.
Thank you. Appreciate that.
Next, we'll move to Lacey Hunter. Welcome, Lacey.
Thank you, Madam Chair, members of the committee. I am Lacey Hunter. I am the Survey Certification and Credentialing Commissioner for KDADS. So my first slide, it is color coordinated. So I know you all can see the colors on it. So I'll try to explain it to you all. So it's a little bit of an update for those of you who are new to the committee, or maybe you don't have some up-to-date knowledge on the federal staffing mandate for nursing facilities. So the way the slide is kind of set up is it talks about what those mandates are. And the first one, it talks about so over on the right-hand side, what the expectations are. And then on the left-hand side, coordinated with the highlighting is the times for which they must be implemented as it currently reads. So the regulations for 1 and 1 at B and C would be required to be put in place on May 26th for facilities that are non-rural and May 10th of 2027 for rural facilities. And then you go down and it's kind of that same there. So the regulations at 483.35B, 1I, and 2 are then unhighlighted on the right-hand side, kind of coordinating when those dates are to go into effect, again, for the rural and non-rural. Next slide, we talk a little bit about with the change in administration. So currently, it's gotten, there's been some communication since we had this, I went back one slide, I'm on slide 10. But because this meeting has been canceled a couple times and our slideshow is from the first one. So there has been a little bit of communication, but for the most part, the U.S. Department of Health and Human Services, or HHS, which houses the Center for Medicare and Medicaid Services, or CMS, as well as the Administration for Community Living, or ACL, has halted most external communications. And this includes guidance, press releases, public speaking, and posting on social media. They have also kind of canceled at this this point, for the most part, reoccurring meetings with state survey agencies, as well as associations. They have also canceled access rule state work group meetings for the next several months. This is common to have this pause in communications when there is a change of administration at the federal level. And then I will point out the little highlighted yellow part on the bottom there, which is that with that staffing mandate, there has been no communication from the federal level to me and my staff as the survey agency who would be looking for these requirements. We have received no training or any word further on this at this point in time. And note that we could not implement this without that training.
Lacey, I'm going to back you up just a little bit, not on your slides specifically, but when you're referring to total nurse staffing, the facility must meet, et cetera, which facilities are you describing?
These are any facility that hold a provider agreement with the Center for Medicare and Medicaid Services. So we're talking skilled nursing facilities and nursing facilities that provide Medicare and Medicaid services.
Thank you. Please proceed.
I think that we can get us to slide 11. So slide 11 and slide 12 are quarter one and quarter two of a requirement that came out of the 2024 legislative session, requiring supplemental healthcare staffing agencies to register with my commission, as well as report on some parameters. So this first slide here is quarter one, which would be July, August, September. And so you can see that within that time, we had 118 total agencies register with our Health Occupational Credentialing Division. Of those 118, 80 of them reported nothing at all to us for quarter one. 9 agencies reported that they were not supplying staff to the required facilities that they would need to report on, and 29 reported that they were supplying staff to those reportable facility types. The reportable facility types include the adult care homes that I license, as well as the hospitals that the Department of Health and Environment license. The next slide is the same information, but it is for quarter two. So we're looking at October, November, December of 2024 on this slide. We had 2 more staffing agencies register, and we had a lot more reporting come in. So our number of people that reported nothing went down drastically. It went down to 13. And what did increase a lot is the number of agencies reporting no assignment at 55, and then, or I'm sorry, 52, and then we had 55 that did report assignments for quarter two. So we had 55 that were providing staff to those qualified facility types. That is the end of my presentation. Happy to stand for questions when appropriate.
And would you explain for those who don't know about the staffing agencies?
Yes, so I'm not gonna get the House bill right, but part of the budget proviso House bill from the legislative session from 2024 required supplemental healthcare staffing agencies that are licensed by me as adult care homes, and then also those that are hospitals licensed by the Department of Health and Environment. If you as a healthcare staffing agency provided registered nurses, licensed practical nurses, certified medication aides, or certified nurse aides, you had to report how many, like the average amount of those types that you provided to that supplier type. So to give you an example, I'm a staffing agency. I supplied those types to a nursing home. I have to report to KDADS the average amount that I charged the nursing home for each of those categories. So the average amount that I as a staffing agency charged the nursing home for an RN. And then I also have to report the average amount that RN actually made. And then it's that for all the categories.
Thank you. Any questions for Lacey, committee? Seeing none, we will move to the Behavioral Health Services and Andy Brown. Welcome, Andy.
Thank you, Chair. Andy Brown, Deputy Secretary for Programs at KDADS. And I'm going to be going over a request that I think kind of came out of the last Bethell, which was to go over kind of what we're doing with data and data collection around our CCBHC program. So in overview, we have a data warehouse that we've worked with the Association of Community Mental Health Centers of Kansas to establish. That allows us to look real time at data that's coming in from the CCBHCs around the state and drill down into that data to analyze it and look at how we can evaluate both performance and also availability of services. one thing that I think is important to know about the project is that this will allow us to sort of measure and know if we are meeting our CCBHC goals for the right time, right place, right provider care that will decrease unnecessary and costly ED visits, our psychiatric hospitalizations, and incarceration. Currently, you can see on the slide that we have 5 centers that are going to be represented. We're going to preview some of the data measurements that are collected currently, and we can also view a little bit of the data from our macro and micro level so that you can see the differences and what those look like. And then we're also going to provide a timeline of the onboarding of the other 21 centers. So when you look at the next slide, increase access to care, from 2023 to 2024, we had an increase of 15.4% of Kansans that were being seen by these first 5 onboarded CCBHCs. So the top line there is your 2024 line, and then your bottom line is the 2023 line, and that represents individuals, unique individuals that were seen by those agencies. This is really a fairly significant increase and shows that the access to care portion of the CCBHC program is providing you guys having trouble with the slides? That's okay. They're part of the original slide deck that we were using for Lacey and Scott. Okay, all right. Okay, thank you. So the total cost of care reimbursement structure to increase the access to services and eliminate wait lists is something that we have been working on in order to make sure that those 9 required CCBHC services are tailored to Kansans across the lifespan. And then on the next slide, this is around improving outcomes. So this looks specifically at Johnson County Community Mental Health Center, and it uses a measure around the PHQ-9, which is a screening tool for depression. And what you're looking at here is over time, the decrease in reported depression amongst patients at Johnson County Community Mental Health Center. So this really looks at how each person who seeks services at the CCBHC is screened for depression at the time of intake, and then what happens at their follow-up screenings at future appointments. So here, we've got about 3,000 individuals that have an initial positive depression screening, with 63% showing a significant improvement, with a 8+ point score change, indicating improvement of symptoms.
Excuse me,
Yep.
Andy, didn't mean to interrupt, but I just want you all to know Renee Erickson, Senator Erickson, has another committee. So we have multiple committees that we all serve on, so she had to leave to go to that. Thank you. Go ahead.
Yeah, no problem. So when we're looking at this, we're really trying to identify what that quality impact is of the care that's being provided by the individual centers. And so the database will allow us to look at each individual CMHC or CCBHC and see how this, their services are impacting things like depression. So on the next slide, we're looking at CCBHC measures. Again, this data that's shown in the graphic is going to be a Johnson County specific graphic indicating the employment status of individuals that they were serving. So all of our CCBHCs have begun collecting data on 5 new CCBHC quality measures that were introduced in January of 2025. Specifically, those are time to services, or ISERV, the depression remission at 6 months, preventative care and screening for alcohol use, and then clinical screening for depression and the presence of a follow-up plan in their treatment records. And then finally, the social drivers of health or social determinants of health. So employment status would be an example of a social driver of health. The quality measure in the community mental health centers is new to CCBHCs. We've had measures that tell us how well hospitals are delivering care as measured by readmissions. We've had measures for FQHCs that are related to physical health outcomes. So these measures are to help us evaluate CCBHCs and really make sure that we're measuring the quality of services in terms of how people with depression are improving over that time period, how their outcomes are impacted by social determinants like their ability to hold a job, provide food for their families, or put a roof over their heads. We're looking at how mental health services combine with interventions for those that are using alcohol or other substances in an unhealthy way, are bending our cost curves in the right direction, and working to equip people to live better, healthier lives in our communities. So this social determinant of health employment is an example, again, of how the CCBHCs are impacting things through services that they're required to provide, like supported employment services using the evidence-based IPS model. And we will also measure how well centers are referring people who are unemployed or underemployed to supported employment. Our objective is to measure how these services are tied together to healthier people contributing to a more fit workforce. And there's also a section on there that refers to people that are not in the labor force. So that could include students as well as individuals that are not seeking employment. And then on the next slide, we have our micro-level data collection example. Again, we're looking at a breakdown from Johnson County here. This shows our CCBHC demographics by age, and you can see that the largest demographic on this is from the ages 20 to 24. So that tells us a couple of things. One, we know that there's a lot of first episode psychosis that's common to that age range. And we also know that it means that there are individuals out there in other age ranges that we could do a better job of engaging with. And when you look at our behavioral mental health profile that we have published by KU, we know that the mental illness diagnoses in Kansas are most prevalent in the ages 18 to 25 category. One of the things that we're doing to work on engaging with earlier interventions is around the 0 to 5 category and looking at how we can use those diagnostic tools and integrate those into our CCBHC systems. On the next slide, you'll see the center onboarding timeline. So currently we have 5 CCBHCs that are in production, and we are in the process of bringing on 9 that are actively in data collection and validation mode. And then by 2025, you'll see that September 2025, we'll have 25 of the 26 CCBHCs online and in production. This will leave us with 1 remaining in Southwest Kansas that will come on by March of 26. On the next slide, you'll see the CCBHC clinic-led measures and additional metrics. These are part of the claims data. We'll be adding claims data over the next couple of weeks to this database system. That data will be updated on a regular basis, and we'll be able to then measure these different bullet points that you see on the slide with real-time data from the CCBHCs and from the utilization.
Andy, if you could tell us the number of the slide, that's helpful because they keep popping off.
Oh, I'm sorry. I think this is on page 21 of the PowerPoint. I think it's page 21. It should be titled CCBHC Clinic-Led Measures and Additional Metrics. Yeah. And so you can see there's a number of measures here that are state-led measures. Those state-led measures are ones that the state is required to report to CMS in addition to the measures that the CCBHCs are required to report to the state. So these allow us to collect that data once we begin moving the billing claims information into the data warehouse. And we'll be able to report on those by the individual CCBHC. So we're hoping that that'll be fully functional and operational in the fall for all of the ones that are coming on board. And then I'm ready to stand for any questions.
I imagine we'll have a few. I'm just going to start with one, and I guess this would be on slide 16, improving outcomes. I'm not sure what I'm looking at here. So we've got PHQ-9.
Yep.
And then it says score of 27, which is the highest possible score. So is this graph here showing me that the cases of depression have gone down, or the number of time? Looks like they've self-report questionnaire looks at symptoms over a 2-week period. Okay, thank you. I'll let you talk.
Yeah, so the PHQ-9 is a screening tool that's used across the state and across the country. We use that tool to ask patients health questions about depression. And so when they report, a period of depression, that qualifies them then to be tracked on this measure, right? So once they've identified that they have a 8-point change in their score, that's what's being tracked across this. So each time that patient comes in after their initial appointment, they're going to receive a follow-up PHQ-9 that'll be rated, and they're looking for change over time and decreasing reporting of symptoms of depression.
What's the overtime? What is this graph indicating as the time period?
Yeah, so I might need to put on some bifocals, but I think that's from 2003 to January of 25.
Oh, I see at the very bottom of the timeline. So it's an overall, an aggregate,
Yes.
correct? Not an individual.
Yep, and it represents about 3,000
Case
patients.
study female, score of 27, so this wasn't one person, this was an aggregate score.
Yeah, it's an aggregate of about 3,000 patients.
Okay, great. And then one last question that I had, and then I'll turn it over to committee, was on slide 18. I'm assuming, of course, MH stands for mental health, but DX, is that diagnosis? What does DX stand for? I see head
Let me
nods
make sure
up
I'm on the right slide here.
18, it has the long blue bar and then the short pink bar.
Yeah, that would be diagnosis.
Diagnosis, all right. Thank you very much. Committee questions. Senator Petty.
Thank you, Madam Chair. So on the slide with the, I guess it's 17, with CCBHC measures, and you have the employment status. So is this just a point in time, or is there, I'm not sure over time what that's going to provide?
Yeah, so this graphic represents the point in time that they reported on their employment status. And this would be, this is the Johnson County data. So it represents all of the patients that they had at the time that we pulled that report. When we do these sort of as real-time data points, whatever the current or most recent employment status is for each patient would be reflected in that circle.
And then you had made the comment about the fact that on slide 19, when you were looking at the breakdown of Johnson County CCBHC demographics, and you mentioned that the highest diagnosis was between, or I guess clients was between 19 and 20, or 20 and 24, and looking at possibly intervention earlier, and you mentioned 0 to 5. So I just wondered, when we looked at that slide, I guess it was on clinic-led measures and additional metrics. So would that be a point where they would be addressing how they're dealing with the 0 to 5?
So right now we have a 0 to 5 work group that's working on implementing service delivery innovations for infants and young children that are in need of mental health services. So what our goal is to try to implement those as practices across the Medicaid system and also with the CCBHCs. And part of that involves both a link with primary care physicians for making referrals, but also in diagnostic criteria and those sorts of steps, which would allow the CCBHC staff to be able to diagnose and treat patients at an earlier time. But when it comes to first episode psychosis, that's something that typically develops in early adulthood.
Okay, thank you.
Additional questions, committee? Representative Ballard.
I think you answered it because I was trying to look at the age range, but you were saying the other, both in adulthood. But how are you able to track the progress or the regression that occurs the closer it gets to adulthood? And I'm assuming you're looking like 16, 17, 18.
Yeah, so the database allows us to really pinpoint and identify data by patient level within those CCBHCs. So we can look at really micro level data at patient tendencies. And then we can also look at the organizational level or CCBHC level data. We should also, in the future, be able to look at individual MCO performance with those patients at the CCBHCs as well.
And what do you consider the range of adulthood?
So generally for Medicaid, we're looking at, we have a psych under 21 benefit, which allows for individuals under 21 years of age to be served in a psychiatric facility by Medicaid. And then anyone over the age of 21 up to 64 would be in that adult range, which would be excluded from institutions for mental disease reimbursement.
Okay. Thank you, Madam Chair.
Senator Petty.
Thanks, Madam Chair. So I'm focusing back on that 0 to 5. So if you have a client that, or if one of our CCBHCs has a client come in, do they also gather information about their parent status? I mean, if they're a parent status, and whether they would have a child that's being serviced through through AMHIT, through the mental health program and interventions programs in our schools?
Yeah, so part of the MHIT program, in a lot of cases, the CCBHC is the school's partner. And so when they're providing services through the MHIT program, there's usually a referral back and forth between the CCBHC and the school about that individual child. For situations where the MHIT provider might not be the CCBHC, when the child or the family does an intake, they would be questioned about what services they were receiving, and then there would be a care coordination process that's established.
Thank you very much, Andy, for being with us. We are going to move now to Managed Care Organizations, Networks, and Value-Added Benefits for 2025. We will start with Sunflower Health Plan. And because of time, each of the MCOs will have 10 minutes total, and then 5 minutes for questions.
Good day, Chairperson and committee members. My name is Jamie Price, and I am the Senior Director of Contracting and Network Development at Sunflower Health Plan. Thank you for having me today. Currently, we are contracted with 27,779 distinct practitioners. We have 835 home and community-based providers, 4,682 primary care physicians, 773 pharmacies, 152 transportation providers. We have a new transportation provider, SafeLink, that has been in our network since November 1st, 2024. We have 473 dentists, and we have 468 optometrists in our network. On the next slide, you will see a percent of members with access, which ranges from 81.9% with pediatric neonatology to 100% of access across many adult and pediatric specialists. And what that is showing you is that the gaps across the specialties that we have are primarily in allergy, dental, hematology and oncology, neonatology, physical medicine and rehabilitation, plastic and reconstructive surgery, and urology. These gaps primarily occur in rural and frontier communities, much like what you heard earlier in an earlier testimony. These shortages of specialists in these rural and frontier counties are often referred to as our provider deserts. And this term highlights areas where healthcare services are scarce or non-existent, leading to gaps in medical care for the residents living in those areas. And factors contributing to these provider deserts include a maldistribution of healthcare workforce and present challenges in recruiting and retaining specialists in these regions. So how do we address that? One way we address it is with telehealth and providing, that if it's appropriate and acceptable to the beneficiary. We also provide non-emergent transportation for members to get to providers that are close by, for them to get to other specialists within the area. We look at providing, seeing if we can get other specialists recruited to come into those areas, maybe providing clinic days with rural health clinics or federally qualified health clinics, and work with them to bring in specialists for clinic days and leveraging some of our rural health providers in that way. We reach out to providers in other states bordering in those areas to see if we can contract with those providers, potentially doing single case agreements when we're unable to contract with those bordering state practitioners and providers under those conditions. And we work with our rural health partners in creative ways and bringing in providers to locations whenever possible. My partner that's going to be testifying next is going to talk about some other creative rural health initiatives that we started employing last year and will continue to do this next year as well. And I know that towards the end, we both will be standing for questions. I don't know if you wanted to ask some questions now or if you want to wait till the end.
We'll hold those to the end.
Okay.
Good morning, Madam Chair, Committee. My name is Maria Salas. I'm the Health Equity Director for Sunflower Health Plan. Thank you for the opportunity to have today to speak about our 2025 value-added benefits. Since 2013, Sunflower Health Plan has been helping Kansas get and stay healthy. At Sunflower Health Plan, we believe that health and true well-being extends far beyond the walls of a doctor's office. Our commitment to the health of our members encompasses every aspect of their life, and we are dedicated to supporting them in maintaining a balanced and healthy lifestyle each and every day. To make sure that our members are equipped with the resources they need, we proudly offer a range of extra services designed to promote long-term wellness and ensure that our members stay their healthiest every step of the way. Our state-approved value-added benefits meet our members' needs and support the goals of KanCare. They promote healthy lifestyles and improve health outcomes among our members. In developing our value-added benefits, Sunflower Health Plan included all suggestions encouraged by the state of Kansas. I've submitted 2 slides that capture our 2025 value-added benefits. And to clarify, these are the extra services provided outside of Medicaid. We've added several new ones this year, and I'll highlight those on the first slide, starting with our vision and mobile clinics. This is a new value-added benefit Sunflower is providing that offers members living in rural areas access to quarterly vision care, which includes vision screenings and prescription glasses. Sunflower also assists our members in coordinating appointments and to access other types of services and screenings while we are at those events. And we also bring and provide in other resources to those events as well. This truly highlights Sunflower commitment to our members in meeting our members where they're at and creating another access point in those rural areas where our members can receive services. Sunflower continues to offer a $10 voucher to provide healthy produce at farmers markets. We continue to offer cell phone services for voice and data and text, health coaching that encompasses a lot of different types of coaching needed from our members, such as stress, nutrition, quitting tobacco. And we also still continue offering our employment support program that creates a bridge for independence for our members. And these are services that we offer, such as GED voucher, test, and career counseling. New this year, we have added enhanced transportation that allows members and a caregiver, if needed, up to 12 round-trip rides within the year to attend events that are socially determinate, that are related to social determinants of health. So that could be a community activity, support groups, or a ride to attend a health education program. We continue to offer online health resources through our Teladoc digital mental health program, and we've added PICS this year, which is a mobile app tool used to reduce social isolation and loneliness. We continue to offer our members healthy rewards. Our members complete healthy activities and earn rewards that they can use to purchase groceries, over-the-counter medications, personal care items, and they can also use those rewards to pay for utilities and childcare and other expenses. Sunflower continues to offer youth programs for all ages, including a Sunny's Kids Club, our annual summit, and we still provide a $50 credit for members in programs like YMCA, Boys and Girls Club, and Girls and Boys Scouts. And the last item, bullet listed here for pregnant and new moms. We support our pregnant and new moms through our Start Smart for Your Baby program. We've enhanced that program to add in a free car seat and booster seat for getting key prenatal care, and also extra support around the first year of life for 0 to 15 months. Mothers can access a maternal child care coordinator to provide those extra supports. On the next slide, we have value-added benefits for members on waivers and other special groups. And again, we have added additional benefits this year, starting with transition services. Members can receive up to $1,500 to buy needed household items, and Sunflower assists with planning transitions and coordinating wellness checks for those members utilizing that benefit. And again, we continue to offer 60 hours of respite care, classes and training that are geared towards specialty training for providers, for members, for caregiving and foster care. We continue to provide home-delivered meals for our FE waiver, frail and elderly members returning home from a nursing home or an inpatient stay. New this year, we've added a $200 benefit for members to receive for holistic treatments performed by a traditional healing practitioner to support physical, mental, and emotional healing. Another new program we've added are for the members living in Harvey County, which is a diabetes education class. And through this program, this is included for members can take advantage of this program that includes cooking and other classes, weekly food boxes, and other tools to support members make a long-term healthy lifestyle changes. And you can read on the rest of these items that are listed on here. And our last item that is new for this year, members on the IDD waiver and wait list may have up to 2 practice dentals this year through their dental provider's office. And this is a way to help them become more familiar with their dental provider, dental care, and treatment to reduce stress at future visits.
Thank you. Committee questions. Senator Petty.
Thank you very much. It was mentioned earlier about with the rate study that's going on, that they're looking at non-emergency transportation, and I noticed that you do provide non-emergency transportation. Are you seeing an increase in that, or is that, of course, the year's just started, but has that been used? Let's use last year's numbers. How is that used?
Yes, so Sunflower provides non-emergency transportation through the Medicaid program, but we also, for this benefit that I described, are enhanced transportation benefits. So these are for the types of rides that our members are needing that doesn't fall into the category of non-emergency transportation. So those are offices, medical providers. These are going to be rides that are not covered through that state benefit, the enhanced benefits for rides. This could be a member needing a ride to an activity center, maybe a type of wellness class, or maybe going to the gym. So some of those social rides that are not covered under non-emergency transportation.
And did you say that they can get 5 of those?
Up to 12 round trips per year.
Okay. Thank you.
Thank you.
Committee, additional questions? I have one. For each of the MCOs that are coming to microphone, I would appreciate it if you would share the number of members that you are serving. And also, don't need to do this today, but I would like to receive a breakdown of like how many pregnant women, for example, et cetera, that are receiving maternity services. Okay?
147,000? And then what was the, sorry.
And this is going to take more time, but a breakdown of the, this many children, this many adults, this many pregnant women, et cetera.
Okay.
So you have an idea of the population that you're serving.
Okay, we can get that.
And that was 147,000, correct? Also included, if you would share how many are dual eligibles.
Absolutely.
Thank you.
Absolutely.
Additional questions, committee. Senator Petty.
Thank you for the added benefits, the extra services. On the pregnant and new moms, you mentioned that you have the Start Smart for your baby program, and then you mentioned it with the car seat or the booster. Do they get those automatically, or if they participate in the Start Smart for your baby and do their prenatal care?
Correct. So if a member is participating in the Start Smart for Your Baby program and they have completed their key prenatal care, we will provide them with a free car seat or a booster seat.
And then you mentioned something else about with the first year of life. Do they have somebody that can assist them?
Yes, they have a direct access to our maternal and child care coordinator. So it's extra supports in addition to what we're already providing through case management. But for that first year of life, we know how vital that is for babies 0 to 15. So we're providing that extra support in addition to everything else that we're providing as well.
And then do you also provide any information for them about other services that are available in their community?
Yes, absolutely. Yes. Yes, we have a robust case management team that assists our members in this population that are pregnant or new moms, that will coordinate care for them, help set up appointments for preventative care for both mom and baby, and we provide them with all of the array of resources that we have.
But do you provide them with any information about the community, the resources that are outside of what you're
Yes.
providing, like, parents as teachers that are available to them, or any of those
Yes.
programs so they can access through their community?
Yes, we do. Our case managers will provide all of the information available in their community specifically, and then also any other type of social services that they may qualify for with us and within the community as well.
Thank you.
Thank you.
I do have a number of dual special, we at 10,500.
Senator Ballard, did you have a question?
She may have answered it. Thank you. I think you might have answered. Oh, I guess I do have one more. We're talking about the ones for babies and prenatal and everything else. For your seniors, what would you say would be your 2 top programs that would be most beneficial to them?
So for
Bring an expert in.
Good morning. Madam Chair, I'm Stephanie Rasmus. I'm Vice President of Long-Term Supports and Services for Sunflower Health Plan. And Representative Ballard, I would say the 2 extra services of the value-added services, one is the rides to community activities. We really have an effort to set goals with seniors on being active with their friends, their family, out in their communities. So I would say that's one. And then the other new one, and we'll see how they like it because it is new, is the app to reduce loneliness within their homes as well. Respite is also very popular.
Thank you very much for answering that question. I was asked that question at a little forum or a group I went to, and I was guessing. And I said I was guessing, but I said transportation would be big. So I thought I better ask to make sure I was right. And the other one was being by yourself, especially if you don't have family close by to come and visit you, or all your friends that you were close to have slowly died around you and you're left by yourself and you don't feel purpose or anything like that. So I did pretty good guessing, so thank you very much.
We actually do, and Madam Chair, I'm sorry, I know we've gone over, but we actually do an annual member satisfaction survey with our long-term services population. That's an independent survey. Get a pretty high rate of return on those. And for seniors, that is a question where we see lower satisfaction scores than with maybe members with IDD, physical disabilities, is doing things with my friends, family, and in the community. So we're separating that question out a little bit more this year and digging in to see, is it because they don't want to go out and they want to do something at home with friends? Is it because they don't feel like there are things to go out and do? But we're asking a few more questions around it to see what we
Maybe
get.
some people to do it with.
Somebody to do it with,
It becomes the real biggie.
And just to make sure the extra services we're offering are the right things to address what people are saying.
Thank you very much. And nice to see you again, too.
And good to see you.
I would also add, I'm assuming the 10,500 dual eligibles, once they become a senior, they would be offered a Medicare Advantage plan that would have all kinds of other additional services, such as, they have $3,000 to $4,000 worth of free dental and all kinds of things that are also given them. Thank you so much. And next, we will turn to UnitedHealthcare.
Good morning, Madam Chair and committee. I am Tim Thomas. I'm the Director of Operations. As we speak, as we pull up our presentation first, our total enrollment is just over 150,600 members currently. We are getting our dual members. Our DSNP membership is over 15,000 currently for DSNP specific. So
I'm sorry, would you repeat that first number?
The membership?
Yes.
150,600. And our slides are not coming up, so I will go off of my phone. For our provider network count, which will be slide 3 when we get to that, we have home and community-based providers, 560, primary care physicians, PCPs, and we have a map of that on our slide 4, 4,600 roughly, pharmacies, 929, transportation providers, we have 101, but that's individual vendors, so to speak, provider groups, not the individual drivers. And in dental providers, we have 476, optometrists, 554. Also, all of this data is available on the KDHE website with the maps available for all of us. Also goes down through the breakdown of the limits that we have for mileage to be able to have gaps. So unfortunately, we won't be able to show our maps, and those were, you're pulling it up, thank you. So we have our maps for our primary care physicians. We have access throughout the state of Kansas without any gaps.
And just FYI, we can all see it here. The committee members have access to your slides.
So slide 4 is the PCPs, and that's a really important piece where we have access everywhere. If a provider is available, they're less likely to use the emergency room. So that access is incredibly important. Slide 5, we have our dental providers, and I want to use this as an important piece. I want you to look at the southwest corner of the state, because we'll come back to this to talk about gaps. So if you see Morton County, that's Elkhart, Kansas. That is a county that when we speak about dental, there are no dentists in Elkhart. So that's a gap that unfortunately we're unable to fill because there's no professionals to fill it. And then 4 counties over, if you look at Meade, Kansas, they do have a new dentist in the community, and so we'll be able to speak about our recruitment efforts, listening to the professionals. So that's really an important distinction there. So also like Ness County, there are no dentists there. Sherman County, we're in close communication with dentists there to try to add and address those gaps. The next slide is our pharmacies and vision. As you can see, we have coverage of the state of Kansas with all of the providers that we have in network. And then finally, we go to the provider network gaps, how those are determined. And these are all contractual by the state of Kansas, by KDHE. We have the time and distance standards based on the type of county. So if they're densely urban, the time and distance is closer than if they're a frontier county, then they're further apart. We work closely in collaboration with KDHE whenever there are gaps identified. We request exceptions. We state what is causing the exception. So are there no providers or are there recruitment efforts? And we work closely with them. Every gap that we have currently, we've been in communication with KDHE, and those exceptions have all been approved currently as of this moment. The next slide has a list of the specific gaps that we have for each type. So going back to the dentist, as you can see, we have Morton County. There are no dentists in that county, so there's nobody to outreach. Thomas County and Meade County, we're actively recruiting. And slide 9 talks about our recruitment strategy. Ultimately, what we do is we want to follow the member. So we look at this in multiple ways. We follow our claims data. Where are our members going to receive services? How can we impact that and sign a contract with providers that there's a desire to be used? We listen to them through member services. So if there's calls where they are unable to find assistance, we work with them. Our care coordination staff, our community health workers live in the communities with our members. We are Kansans helping Kansans, and we listen to them. In fact, we had an NEMT service where one of our care coordinators found a new stretcher provider. They worked closely with our vendor oversight manager. We got them under contract with our subdelegate, addressing a gap in every way possible. So there's no wrong entry into UnitedHealthcare is really a key piece that we work at. And then we're moving forward our digital experience. So in the past year, we've increased our app experience where utilization has increased by 298%. And effective January 1st, we have added a digital urgent care. So members, if they may be on a Friday night at 11 o'clock are unable to see their PCP, Obviously, emergency rooms are a quick thought. We now have an urgent care available for them on the app to help with triage of that and prevent unnecessary emergency room. So that's kind of the large picture access that we have. Next, Laura Canellis will come up to talk about our VABs, which is another access point, and I'll stand for questions at the appropriate time.
Good morning. We can go to the next slide, please. So we're going to talk a little bit about value-added benefits. In a second, you're going to see a full list towards the end, but I wanted to touch a little bit on how we decide and how we analyze what benefits we want to keep and which ones we want to enhance, maybe which ones we want to add. So we can go to the next slide. And here are some of the considerations that we see. So health impact, of course, and addressing social determinants of health. These added benefits are always keeping in mind how do we support the members in their health journey. We listen to the member and to the community and the providers as well as community partners to see what is working, what might look really good on paper but is actually not being utilized, or members are having a hard time accessing, or they are really not needed. And the need and utilization are also another consideration. We see data of how many members are accessing each benefit and the feedback that we hear from them when they're having problems not getting what they need. So it's several considerations that we look at to decide what we want to keep and what we want to keep enhancing for the next years. So with that, in the past years, we've done a lot of modifications to those offerings, and we've seen some very good results. So we can go to the next slide. These are highlights of the main benefits that we see having a bigger impact. For waiver members, we have free internet access when it's something that could support them in accessing telehealth. We have pest control for members that own their own homes and are needing that service. We have an OTC network reward for waiver members, so all of these members receive a $50 reward so they can pay for things that are over the counter. And this year we have a new one that is a membership to a grocery delivery service. Again, because we've been hearing that due to transportation issues or mobility issues, they cannot go to the grocery store, so we wanted to add these, and we're seeing really good results with that. For members that are pregnant or new moms, we have nutrition for high-risk pregnancy. They receive, it's a very nice program that through a website they can access healthy foods and they decide which healthy foods they can purchase. We have the baby script rewards and the first trimester exam reward that is also $75 when they do that prenatal care. A lot of these benefits are with that lens in mind of incentivizing members to care about their preventative health. And a pack and play when they do attend a community baby shower and receive education. An in-home visit reward. This one is new. So when our team of maternal health workers are assisting a member and they complete an in-home visit, they can get that $50 reward. And then for kids and a lot of our members, we have air purifiers, bike helmets, and weighted blankets. This is something that we really listen to the community of wanting something more tangible that could also be health-related and help them prevent accidents. As well, the weighted blankets help tremendously with issues of anxiety, particularly in some of our waiver population, and air purifiers for children that have an asthma diagnosis. So again, preventative health in mind. We offer the activities, clubs, fitness, kids, or sports balls. That was also based on community feedback that we received because depending on what area they live at, they might not have a YMCA close by. So instead, we ship them a fitness kit or a sports ball to help support their journey on exercise. And we also added an OTC reward for members in those rural and frontier counties because they might not get the ability to access the benefits that other members in urban areas can. And the next slide has a list that I'm not going to read to you because you'll have that of our full offering. Again, the new ones are highlighted. A lot of these are pretty similar to what all the other MCOs offer. One that is an excellent one, I believe, is the transportation one. We have 24 extra rides for our members, and we consider that anything is health-related, except when it's explicitly not. And we're especially excited about these grocery delivery services for our members that are having mobility issues, because that would allow them a level of independence and dignity in how they access those groceries. So I'm open for questions. If you want to know about any more of these, we're here to
Thank you
assist.
so much. Thank you both. Committee, are there questions from United? I'm sorry,
because
I just recognized.
That's fine.
That's all right. Yes, Representative Bryce.
Thank you, Madam Chair. Yes, this is a question for the first gentleman. I appreciate your information about directing patients to the appropriate site rather than emergency room, perhaps. I have maybe a logistical question for you, and maybe it's just my lack of understanding, but let's say a patient goes to a clinic, it's a Medicaid member, goes to a clinic, and they're seen by the provider there. How do you know that the patient being treated is the same patient on the Medicaid card that is a member?
I believe that would be done by the office staff. So they have the cards, they have the IDs, the names, there's the HIPAA validation that would occur. The same the HIPAA validation that would occur when people call the clearinghouse, for instance, or ourselves. So there's all of the personally identifiable information that would be available.
Just a quick question. There was the Inspector General testified earlier. You may have heard some of that. In my personal experience, I know of people who, for instance, have their knee replaced using their cousin's Medicaid card, tens of thousands of dollars. I know of patients that I've seen in busy clinics. One week they weigh 180 pounds, the next week they weigh 120, and it's obviously people that are using the same Medicaid card, maybe even the same ID. And I was wondering, the Inspector General was speaking of increasing FTEs and manpower to detect fraud. That's not only provider fraud, but member fraud, obviously. I don't know how big of a problem it is, but I know I do run into it. And do you have any thoughts? Maybe this is out of your wheelhouse, but do you have any thoughts about do any of the programs have biometrics or any way of making sure the person being treated is the person that should be treated? I know identity cards can be shared and so forth. Just any comments you have. Thank you.
We don't have biometrics or any of that, but I think that we rely as the healthcare system as a whole. If we see a weight change of 60 pounds, that would be something that I would assume that the Attorney General, the IG would appreciate to know about. But no, there's no biometrics. There's no large scale pieces that we do with that.
Just one quick last question. And maybe you could answer this, maybe not, but how complicated or how feasible would it be to have some kind of a biometric requirement in order to cut out, if it is a significant amount of fraud, in order to cut that out? Thank you.
Yeah, and I'm not aware of any assessments that have been done, but our CEO, Jenny Ismert, could speak if that's.
Hi. Good afternoon. Jenny Ismert. I'm the CEO for UnitedHealthcare. I would say I can't really speak to the delivery system's ability to adopt, sophisticated technology like biometrics. But what I would tell you is that as an MCO, we have very robust fraud, waste, and abuse processes that we apply across all of the claims that we're receiving in the system. We're not checking at the individual patient level, that physicians are actually, working through their process to ensure that individual is on the ID card, but we are applying our fraud, waste, and abuse processes to everything that we're looking at as a managed care organization.
Okay, thank you, Madam Chair.
Representative Ballard.
Thank you. I'm going to ask you the same two questions, but before I do that, I would say if someone would go to the doctor's office that I go to now, they wouldn't be able to go in because I've been going to the same doctor's office for 20-some years, and every time it says, "May I see your card?" Or "Have I run it yet this year?" Or they know who I am. They know my name. They say, is your address the same? And sometimes they don't even have to look at the card, but they'll read it and everything else. So they would have a hard time. So some of those people send them to mine, okay? And they won't be getting any kind of free service because once in a while I didn't have my card. And I thought I was going to have to go home and get it because I had changed purse. But somebody says, well, I'll vouch for her. I know where she is. I know where she lives. In fact, I can even tell you what her number is. So That's mine. But my question, I would like to ask the same thing I asked the other two, because I don't want the two of you feel slighted. What would be your two most dependable ones for frail elderly?
So the frail elderly, I spoke with Melanie Dowling, our director, and she mentioned home-delivered meals is another critical piece. And then she was in agreement with Sunflower with the transportation pieces. So in addition to loneliness, transportation, the home-delivered meals, which is a covered benefit, but we also have an additional value-added benefit. And then Laura mentioned the grocery delivery. We're eagerly anticipating what that impact is going to be.
Ooh, that's a good one. Okay, thank you very much.
Representative Ruiz, we have just real quick here. Do you have a question for us?
I do. One is, I think there's a discrepancy in the number of pharmacies in the slides. On slide 3, it indicates that there's 929 pharmacies. But when I did the math, which I really don't like doing math, when I did the math on the network maps, it looks like it's more like 600 and something.
I'll have to work with our analysts to determine what the discrepancy is there.
And then real quick, because this is very shocking. You look at slide 8 for the managed care for the network gaps, the neonatology, that is shocking, the gaps in that in the county. I think that's something that's we should be focusing on. Thank you, Madam Chair.
Thank you so much. Next, we will move to Healthy Blue Kansas.
Thank you.
And Brian, I believe you're virtual with us.
Yes, I am. Thanks, Chairman.
Sorry to hear you're under the weather. That's kind of going around. Please proceed.
Yeah, I had planned to come in today, but woke up with chills and a fever. So although there's some in the gallery I'd like to share it with, I thought it'd be best not to be in person today. All right, well, I've got 9 slides in 10 minutes, so it's to average a minute a slide almost. And I'm assuming you guys have it in front of you.
Yes, we do.
Okay. All right, so get the title slide, and then the first slide really is Kansas Roots Medicaid Experience. And this is really what was our theme for answering the RFP and in our proposal. We're an alliance between the 2 Kansas Blue Cross plans, Blue Cross Blue Shield of Kansas City and Blue Cross Blue Shield of Kansas, combined nationally with Elevance Health, which we think gives Kansans the best of both worlds, gives a local health insurer with more than 1 million Kansans currently served in an alliance with a national partner who's one of the largest Medicaid managed care organizations in the country. So similar to the organizations with Kansas Roots Medicaid Experience, I'm a native Kansan, 5th generation, born in Hayes, and have spent the last 25 years working nationally on Medicaid issues in multiple states and national roles for several managed care organizations. So that's kind of our approach to the state of Kansas. On the next slide, just sharing some of our goals, and really our goals are the state's goals. We want to improve member experience. We want to improve and simplify the provider experience. And we want to collaborate in improving the program where and how we can by leveraging data, bringing innovation, and incentivizing and encouraging members to engage in their own health. Our next slide is our network approach. And so what we're bringing to the state of Kansas, we're leveraging the networks of the 2 Blues Alliance partners. They serve currently over 1 million Kansans and have the largest network in the state in all 105 counties. And then we're combining that with an approach to providers to simplify their experience, some standardized elements, some streamlined credentialing, and then communications with the providers to make their experience as good and easy for them as possible, because we know Medicaid isn't always the best payer. And so we're looking to make it a good experience for them to encourage them to participate in the program. Our network, besides the approach of being collaborative with the partners, we were ready for network adequacy 2 months ahead of schedule before go live. This really allowed us to have a smooth implementation for the state of Kansas. On the next slide, specifically the network status. We really look at it in two buckets. One are the urban counties, which definition is more than 40 people per square mile, versus the rural counties, which would be less than 40 people per square mile. In the urban counties, we meet 100% network adequacy today. And in the rural areas, we're at 86%, so we have some work to do there. On the right-hand side of that, slide, you can see where we have the work to do. And similar to the other MCOs, primarily in pediatric subspecialties and allergy. So we're going to have to do some strategies there to recruit additional providers. And if they aren't there, we're going to have to get creative and make sure we have a good transportation benefit to make sure that those members can get those services from an adjacent county or nearby town if it's not available in their area. Moving to the final network slide. Right now, our unique provider count is 48,185. And for the provider counts that may be of interest, 6,185 in primary care, over 5,000 in the HCBS network, 593 pharmacies, 686 transportation vendors, 402 dentists, and then 303 optometrists. Switching a little to the value added benefits. I know there's a very busy slide, difficult to kind of take in, but I did want to address that really the value added benefits are a small piece of a really large strategy. And what we're trying to do through these strategies is improve health outcomes, encourage the member to take control of their own care, and then really work to encourage and incentivize members to seek preventive care versus episodic or ER care. So most of the value added benefits we'll talk about are tied to a positive event where the member is seeking preventive care and not seeking it through the ER, or they're doing something that will improve their health outcomes and hopefully avoid an episodic incident where they're at the ER. Or they're doing something where it's an adherence to the treatment that they've been prescribed by a physician or other health professional. And if they stay adherent, we'll keep them out of the ER. So really the approach to the members is to get them to take control of their own health care, and value-added benefits are just one small piece of that puzzle. On the next page, highlighting some specific value-added benefits. We do have a smartphone preloaded with our member portal. It's the same app I have on my commercial insurance where I can check to see if I've got lab results or if I need to make an appointment or if I am eligible for any health rewards for having gotten a preventive visit. So that's an important value-added benefit. Also, that last one under the heart, the over-the-counter benefit. A number of states that do fee-for-service pharmacy, their number one prescribed drug is ibuprofen. And that's because to the member, if they go buy ibuprofen from the counter, the drugstore, they have to pay that out of pocket. But if they go to a physician and get a prescription for it, then it's a covered benefit. So this is another example of where just by providing a more efficient setting, we can reduce costs to the program and make sure they have an over-the-counter benefit so they don't have to go get a prescription to get drugs that are available over the counter. And again, all the lists on here, these are all programs and incentives that are trying to deliver cost-effective care. Most of them are tied to doing some kind of preventive health care or achieving a good health outcome, or there's a behavioral health component for mental health. So really one of those three buckets is what we're trying to achieve with those value-added benefits. And then the final slide, you'll see the complete list of value-added benefits. Won't go over all of these unless you really want to. But I'll point out a couple. So one, third one down there, the ID support. This one has been kind of our most surprising benefit. We have helped 400 Kansans get their ID, primarily their driver's license, through this program. And that's important so that they have transportation and access to get to doctor's appointments or the pharmacy or even to a job interview to get employment and get off the Medicaid program. And so a Medicaid beneficiary may not have the documents needed to get a driver's license, or they may not have the money. There's a $29 fee to get the driver's license, and then if you don't have the documents, you're having to spend $25 to get a certified birth certificate. So anyway, that's one benefit we provided that I was kind of surprised in the take-up of that. The first 6 or 7 benefits you see here are about independence. They are about helping that member, improve themselves and potentially get rid of barriers that would prevent them from getting employment. So those are helpful to the member in really taking control of their own healthcare and their own, achieving their best self. Another benefit I'll point out is about 2/3 of the way down on the left is the dental desensitization kits. Kansas is our first state offering this. These are kits to help IDD waiver children get more comfortable visiting the dentist. And so for autistic or IDD child, it may be troubling to sit in a dentist chair and have them poke and stick you with various instruments. And this is a kit that allows mom and dad to sit down with the kid at home and get them used to what's going to happen at the dentist office. And so we have seen good pickup in that in the IDD community, and we'll be interested to see the results of that value-added benefit and if that helps us improve getting those populations to the dentist. So overall, these are our lists, and similar to the others, these are really designed to encourage preventive care or taking control of their own health care or improving health outcomes and avoiding
Thank you, Brian. You were right on time with your 10 minutes. Committee, are there questions for Brian?
Yes.
Yes, Senator or Representative Bryce.
You keep giving me a promotion. Thank you, Chairman. Thank you, sir, for your testimony. Just a quick question. I'm thinking about efficiencies and cost savings. Can you tell me, are there explanation of benefits mailed to members that are seen by providers? EOBs?
Yeah, no, obviously the member gets the EOB. The provider would get the claim. So I'm not sure if they technically get an EOB. I can find out for you, though.
Okay. Just the reason I was asking, that my understanding was they do not, and I know, and that could be wrong, I'm sorry, but that's my understanding. And I know when I go to a doctor, I have a procedure, I'm hospitalized, I get an explanation of benefits, and I always cross-check that because inevitably there's something on there that is wrong. And so it's kind of a way of keeping the providers in line. If you want to look at it in that sort of way. But do you think that having an explanation of benefits for Medicaid recipients would help them to see things that were, we had testimony earlier from the Inspector General about the level of fraud. Would that be helpful, do you think, in preventing unnecessary payments for procedures and items that were not accurate? Thank you.
Yeah, no, and I get EOBs too, and a little difficult even for me with a law degree to sometimes understand what they're showing. But I do believe the Medicaid members, and I'll double check this, that they do get the EOB and are able to cross-reference that with the services they got.
Okay, well, thank you. If they do, I'd like to know that. If not, that might be something to look into, Madam Chairman. Thank you.
Additional questions?
Yes.
Representative Ballard.
And I would like to ask the same question I asked before. Can you give us or share with us 2 extra items that you offer that would be most beneficial to your frail and elderly, or just your elderly people?
Sure, and obviously the transportation, and so we do offer 30 additional round trips for transportation. And so they can use that to, go to activities or groceries, those activities. We also have a number of loneliness programs where they can get peer support or join social groups, use an app. There's a chat function where they can talk with other people in a similar position. So trying to get them more connected and overcome some of those feelings of loneliness.
Thank you very much. I appreciate it. Thank you, Madam Chair.
And Representative Bryce, I can confirm we do send EOBs to members so they can double check the services they received.
Great, thank you, sir.
Our last question is from Senator Petty, and then we need to close.
Two things. One, how many clients do you have in Kansas?
Yeah, thanks. I forgot to cover that. So we have 115,000. We're the new guy, so we're starting a little lower than the other two. We have 2,000 members in dual special needs plans, and that just started up in October. And I don't know the number we have in maternity currently.
Thank you. And then you had this highlighted value-added benefits, and then you had that long list. So I'm looking at the prenatal and postpartum items. And so are those then available to, along with others, to every new mom, or when it comes to the nursing and maternity support items, are all those available, or just in specific circumstances?
Yeah, well, the nursing items would only be available to moms, to new moms. So there are some condition-specific ones, right? So if I'm on IDD waiver, I wouldn't be eligible for nursing and maternity support items or baby essential items.
Right.
Such as getting
Right. I was just really speaking to whether these were available to prenatal and postpartum.
Yes.
Okay, thank you.
Thank you, everybody, for being here today and for this, again, a cold Friday morning. And we really appreciate you. And committee, we are adjourned. Oh, I forgot to announcement. I'm sorry. For the Senate Public Health and Welfare, we will be meeting on Tuesday, Wednesday, and Thursday next week. And the agenda will be coming out later today. Thank you.